and good morning. The Honorable, the Rector of Hasanuddin University today is being represented by Vice Rector for Research, Innovation, and Partnership. Good morning, Professor Dr. Muhammad Nasrul Masri, Ph.D, SPMK. Welcome, Professor. The Honorable, the Dean of Dentistry Faculty, Hasanuddin University. Good morning, Dr. Muhammad Ruslin, M.Kes, Ph.D, Spesialis Bedah Mulut Konsultan. The Honorable, all our international and national speakers, dear participants, ladies and gentlemen, we'd like to warmly welcome you all today in the 4th International Conference on Biophysical Technology in Dentistry in theme Welcoming New Normal in Dentistry During and After Pandemic from Dental Research to Dental Practice. Ladies and gentlemen, as the beginning of our conference for today, this is Indonesian Anthem, Indonesia Raya. Ladies and gentlemen, next is a brief report from the chairman of the committee of the conference to Dr. Gigi Al-Karama Mardika. Please, the time is yours.
Thank you for the opportunity. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. All praise is due to Allah, to God, for enabling us to meet together in this 4th International Conference on Biophysical Technology in Dentistry. The Honorable, the Vice Rector of Research, Innovation and Partnership, Hasanuddin University, Professor Dr. Muhammad Nasrul Masri, Ph.D. The Honorable, the Dean of Faculty of Dentistry, Hasanuddin University, Dr. Gigi Muhammad Ruslin, Ph.D, SPM Consultant. The Honorable, all of the speaker and the participant. Thank you for your coming today. I would like to say thank you very much for the entire committee of this 4th International Conference on Biophysical Technology in Dentistry for their hard work to prepare this virtual conference. In the midst of COVID pandemic that has spread globally, we do not lose courage and spirit to hold our annual scientific meeting. The theme of this conference is Welcoming the New Normal in Dentistry During and After Pandemic, from Dental Research to Dental Practice. This conference aims to discuss about the change in dentistry life during this pandemic. The event will last for 3 days. followed by 41 speakers for a short lecture and 17 speakers for main lecture. As for the main speaker consists of 8 countries such as Taiwan, Japan, South Korea, Australia, Thailand, Yemen, Malaysia, and of course speakers from Indonesia. I do hope that we will get a lot of update knowledge and information from this conference. And in this opportunity, I represent the entire committee hope that this conference will be beneficial to all of us. Thank you very much for your coming. Stay safe and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Kara. And dear participant, next is a remark that will be delivered by the Dean of Dentistry Faculty, Hasanuddin University, to Dr. Gigi Muhammad Ruslin, M.Kes, Ph.D, Specialist Bedah Mulut Consultant. Please, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. The Honorable Rector of Hasanuddin University, represented by Vice Rector of Research, Innovation and Partnership, the Honorable all the international and national speakers, the Honorable Chief of the Committee, all organization committee, and Honorable all of our participants, ladies and gentlemen. Alhamdulillah, all praise and thanksgiving to Allah Subhanahu wa Ta'ala, God the Almighty, for the abundance of blessing given to us so that we can attend this event. The 4th International Conference on Biophysical Technology in Dentistry is the first in the series held in a virtual way due to the pandemic season, because the previous ICOBTD was always held in the direct face-to-face seminar or offline seminar. But we are really glad that pandemic situation not become an obstacle for us to keep in depth our knowledge in this biophysical technology in dentistry. The speakers in this event consist of international, national, and also local speakers from Hasanuddin University. This event covers the presentation of original research, report, and also systemic review. Our appreciation to the Rector of Hasanuddin University, and this time represented with Vice Rector, for all the support for this event. I'm also thankful to all the committee for the contribution and the hard work so this event can be held successfully. At the end of my speech, I would like to apologize to all of the components when in the implementation of this event there were some shortcomings. Sekian, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Doctor. And moving up to our next, we will listen a speech that will be delivered by Rector of Hasanuddin University. Today is being represented by the Vice Rector of Research, Innovation, and Partnership, and also we'd like to the Vice Rector to officially start our conference for today. The Professor Dr. Muhammad Masrur Masri, Ph.D, Sp.K. Please, the time is yours.
Thank you very much. Can you hear my voice?
Yes, loud and clear, sir.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera. Good morning, everybody. At first, my colleague, I want to say hello to my colleague, the Dean of Dentistry, Dr. Ruslin, and the speaker, all speaker from international and national guest speaker. I want to say hello at first for Professor Yung-Kang from Taipei Medical University, Taiwan. Thank you very much for joining. The second is Professor Peter Anderson, Australian Craniofacial Unit. Yeah, thank you. And for the third is Professor Keng Liang Q, Department of Dentistry, Taipei Medical University, Taiwan. Next, Professor Kanchu from Department of Pathobiological Science, Hokkaido University, Japan. Ohayo gozaimasu. Professor Jong-Yuk Kim from South Korea. Professor Boy Muhlis Bahtiar from Faculty of Dentistry, University of Indonesia.
Good morning.
Good morning. Professor Aisyah Hussein, yeah, from Sana'a University, Yemen. I hope your time is almost the same with our time in Makassar. Professor Tuti Ningseh Muhammad Dom from University Kebangsaan Malaysia. Selamat pagi. My colleague from University of Indonesia, Department of Respiratory Medicine, Dr. Erlina Burhan. Selamat pagi, Dok.
Selamat pagi. Selamat pagi,
Selamat ketemu lagi, Dok.
Ya.
And Dr. Lorji Mar Morilla from Master of Oral Diagnostic Science in Thailand. And other colleague from a speaker from Universitas Hasanuddin. Thank you very much for joining in this international conference on biophysical technology in dentistry. This is the fourth one with the theme New Normal in Dentistry During and After Pandemic, from dental research and dental practice. At first, I'm very sorry that our rectors cannot join in this conference because at the same time he is a speaker in another activity. And I'm as a vice rector for research, innovation, and partnership. So I'm very happy that if we always support this kind of activity, especially for the conference, international conference, who invited many speakers from international. So it means that UNHAS can be as one of the university who want to develop their activity to become a world-class university. We always support all this kind of activity, so it means that almost study program, we always ask them to make it this kind of activity, to make it many collaboration, especially international collaboration. And especially for our guest speaker for international, I hope that this is not only as this time you are as a speaker, but we hope that many kind of research collaboration can be done in the future, especially for the Island, and even in any island in Indonesia, and we can make it link together. They have a study program from undergraduate and postgraduate and specialized.
Okay, thank you very much, Professor. Ladies and gentlemen, that was the end of our opening ceremony for today. I would like to thank you to Vice Rector of Hasanuddin University for attending and also to officially start our conference for today. And we're moving up to our first session for today. There will be a presentation about influence of COVID-19 in dental education in Japan that will be delivered by Professor Kanchu from Japan, and also the management of COVID towards new normal adaptation that will be delivered by Dr. Erlina Burhan, M.Sc, Ph.D, Sp.P consultant. And as the chairman for the session will be Dr. Gigi Acing Habibi, Ph.D, Sp.Pros. I would like to give a brief curriculum vitae of the chairman. Born in Atapange, February 1981, graduated as a dentist from Hasanuddin University, graduated as a specialist of Orthodontic from Hasanuddin University, PhD graduation in occlusal and oral functional rehabilitation from Hokkaido University. The chairman, please. The floor is yours.
Thank you very much, Dr. Yoshi. Okay, could you hear my voice?
Yes, it's clear, doctor.
Okay, thank you very much. Okay, good morning, everyone, ladies and gentlemen. So, the Honorable Rector of Hasanuddin University, represented by Vice Rector of Research Innovation and Partnership Field, Prof. Nasrun, the Honorable Dean of Faculty of Dentistry, and then all invited speaker from another country, and then also from Indonesia. Thank you very much for joining with us. And also I would like to say thank you to organizing committee allowing me to manage 2 sessions today as the first session of this meeting. The first session would be a lecture from Professor Kanchu, the honorable speaker from Hokkaido University. Prof. Tay will deliver a lecture about the influence of COVID-19 in dental education in Japan. So I would like to say hello to our first speaker, Professor Kanchu. How are you today?
Hello, good morning. Good morning.
Yeah, good morning.
Already.
How are you today?
Yeah,
okay,
fine.
Thank you.
Thank you.
Really nice to meet you, Professor, even though by virtual meeting. How about the climate in Hokkaido today, Professor?
Very hot.
Oh, very today. Hot. I think it's I think it's summer in Japan now, on August.
Yeah.
Okay. Thank you very much, Prof. Tay. Before Prof. Kancho deliver this lecture, so please allow me to read the curriculum vitae of Professor Kancho Tay. So currently, he is a professor in Department of Oral and Maxillofacial Surgery, Faculty of Dental Medicine, Hokkaido University. Professor Tay graduated in 1982 SDDS in Hokkaido, and then from 82 to 84 as residency in Oral and Maxillofacial Surgery, and also he took residency in anesthesiology, also in radiology. So he has so many expert field. And then in 1992, he graduated as a Ph.D. in Hokkaido University. And then in 2007 until 2008, visiting scholar in Baltimore, USA. So I think he has so many academic appointments as well. So because we have no much time, and I'm sorry for the delay of the presentation, Prof. Tay, because we have a opening ceremony. So Professor Tay, after you make a presentation, so we will open the discussion session for participants who want to give a question or maybe a comment regarding to your lecture. So please, Professor Tay, the time is yours.
Thank you, Professor, and all doctors who made concern. Good morning, ladies and gentlemen. I'm Kanchu of the Faculty of Dental Medicine, Hokkaido University, Sapporo, Japan. Can you hear me?
It's okay.
Yes.
Okay.
Very clear. Yes.
Okay. So I'm very honored to join this meeting. Today, I wish to tell about and show the influence the current situation and the measures for dealing with the COVID-19 in dental education and the practice, especially for oral and maxillofacial surgery in Japan. Wait a minute.
Kemarin dia kasih gambar itu.
I cannot proceed my slide. Okay.
Maybe you need to reshare again. Okay.
Okay, okay.
Yeah.
Okay. Sorry. The slide here shows the COVID-19 situation in Japan. Japan is at the limb of the eastern part of Asia here. The number of patients with COVID-19 increased steeply in April. You can see here. And on April 7th, the Japanese government decided to issue an emergency declaration for 7 prefectures, including Tokyo, Kanagawa, Osaka, and 4 more areas. Then, on April 16, the government decided to issue an emergency declaration for all of Japan. Yes, for Japan. And then, after that, the streets became quiet, like this. And the effect of the emergency declaration showed by the decrease in patient number. The Japanese government decided to lift the all Japan emergency on May 25. The COVID-19 has settled down after a very active period, and society started to return to normal for a little while. However, from July, the number of the PCR test positive people increased again to amount to 1,500 patients per day. But the government did not issue an emergency declaration again due to prioritizing the economy. This slide shows the COVID-19 in Hokkaido. Hokkaido Prefecture is the northern part of Japan here, and this here is Sapporo, Hokkaido University here. Sapporo is even every year we have the Sapporo Snow Festival, this one, which is a worldwide famous event. But the Sapporo Snow Festival became the first step to trigger COVID-19 in Hokkaido this time. Please look at the black line in the graph for the current number of patients. The governor of Hokkaido originally decided on an emergency declaration for Hokkaido on February 28 and lifted the emergency in Hokkaido on March 19. This period was the first wave in Hokkaido. The period from the emergency declaration till lifting the emergency for all of Japan was the second wave in Hokkaido. The COVID-19 has now settled down in Hokkaido too. In Japan, the school and work year starts in April, and the COVID-19 hit Japan directly in this March and April period this year. Most of activity in Japan, such as education, business, medical care, sports, culture, lifestyle, and so on, stopped in the new year from April. Our university graduation ceremony, entrance ceremony, and spring events such as Hanami in Japan that involve partying with watching cherry blossom and spring festival were canceled. Generally, the motivation of people in Japan became very low. The spread of the COVID-19 became serious in April. The Japanese government banned students from attending primary school, junior high school, and university. The COVID-19 have settled down after this very busy period in Japan. Finally, the new year in Japan started in June in this year. However, the current situation is characterized by delays in education, economic slump, collapse in medical service provision, changes in lifestyle. Here I will show the influence of COVID-19 on dental education in Japan. Under the situation this year, there are 29 university schools of dentistry and dental college in Japan. The 29 universities include 11 national, 1 public, and 70 private universities. We investigate the situation at the 12 national and public universities. Each university became affected by control in March, and in April, students were banned from attending the school. The results were as follows. Lecture, here. 7 conducted these on schedule, and there were delays at 5. Training on phantom, none on schedule, and at all 12 they were delayed. Clinical training, none on schedule, and at all 12 they were delayed. Training with fellow students, 2 on schedule, and 10 delayed. Training and experiment in basic dentistry, 1 on schedule and 11 delayed. Overall, we think the influence is considerable and serious. We wanted to start from where we could do everything right away. However, we had to carry out our lecture remotely. Now, today we have been able to catch up with lecture by remote teaching of lecture. But no university can conduct clinical training in the hospital, and the same holds for training on phantoms. Now, for the problem for dental education in this situation. The photographs show the normal situation of dental education in Hokkaido University. 1. Problem for remote lectures. Lectures have largely caught up by remote lecture by now, but there are some problems. We cannot know the reaction, understanding, and learning state of students because we cannot catch on to the student's situation directly. It is difficult to evaluate and give grade. We cannot set examination paper conventionally in the current situation. Sometimes the internet does not work well. Number 2, problem with training on phantom. We must change the training specifics due to training time reduction. There were not enough masks and gloves for the training. Recently, the supply of the masks and gloves have become adequate. It is difficult to comply with the 3 C's. 3 C's are to avoid closed spaces, crowded places, and close contact settings. But the standard environment of phantom training violates all of the 3 C's. We cannot practice with all class members because the environment of the phantom training violates the 3 C's. Therefore, we must carry out the phantom training with half classes, and more training time and teaching manpower are needed. Shields on the training desk are necessary in the phantom training. but there are not enough chairs in every university. Number 3, problem with clinical training. Clinical training stop now. Off-campus clinical training is cancelled. The student cannot recover this learning opportunity from another angle. It is difficult to develop clinical skill in students. Simulation cannot complement some of the parts of clinical training in hospital. Number 4, problem with training with fellow students. That's the same. Training is with fellow students is stopped now. We must change what we do in training due to training time reduction. This slide shows the other problem that matters not covered. We cannot know the mental health and the economic situation of the student well enough. The education of dental school has a specialized program. Therefore, it is difficult to make it fit in by only the business continuity plans of the administrative office of the university. The student cannot learn clinical training in the university hospital. There are some students who became isolated. It is and will be difficult to accommodate to the second or the third wave of the COVID-19. The Ministry of Education, Culture, Sports, Science and Technology instructed us to share flexibility of accreditation to each university. But we have doubts that the student will be able to graduate with sufficient skills now. The basic approach is to avoid the slices. Slices means closed space, crowded place, close contact setting. But just to avoid the slices is not suitable for the dental education. It is difficult to control the environment of dental education in the lectures and training. For example, lecture rooms and training room are narrow, making social distancing problematic. Therefore, we must provide ways around this for lecture, training, and experiment in the dental education. The slide shows our measures for preventing COVID-19 outbreaks in Hokkaido University School of Dental Medicine. The first is hand disinfection at the entrance and the wearing of masks. About lecture, we set an examination paper as in the conventional style due to the understanding we expect from the knowledge of our students. We used 2 lecture rooms for classes to keep social distancing with schedule control for the school years. Training on phantom. Phantom training is carried out to each half of classes. The students use mask, gloves, and face shield. We use desk shield to keep social distancing. Desk shield. These desk shields are handmade by us. We changed the models of the training due to the training time reduction, and we strengthened the prior running before phantom training with video distribution of procedure and techniques so we can use the limited training time more effectively. For the clinical training and training with fellow students, we instruct the student to avoid slices as much as possible in clinical training and training with fellow students. We change what we do in the training due to training time reduction. The student use mask, gloves, goggle, face shield, gown, and extra vacuum as aerosol reduction measures. And we replace some parts of the clinical training with simulator training. However, our university hospital does not accept student participation now. The School of Medicine, Dentistry, Pharmacy, and Nursing feel it as causing a lot of trouble. This photograph is from the end date of the clinical training of the final grade student. The students show happiness and relief. And this is the graduation ceremony of our School of Dental Medicine. It is the start of life as a dentist for the graduates. We have to have a good understanding of the current situation of our students and the problem they face. And we do our best to provide good conditions for our students with various devices and in various ways. Because people expected and wait for graduation and development of good dentists. Now I need to move to next topic. Before the Japanese government issued the emergency declaration here, we at JSOMS is means Japanese Society of Oral and Maxillofacial Surgeons. JSOMS issued a note matters related to oral and maxillofacial surgery during the COVID-19 outbreak on March 31st. We point out the 10 tips as shown in the slide here. First, we should be aware that the risk of new coronavirus infection from the generated aerosol is higher in oral surgery practice than in other fields. This slide shows the condition for patients who should postpone their medical treatment. Patients with a fever of 37.5 degrees or higher and coughing. Patients who have a history of overseas travel with the past 14 days. Patients who have a history of close contact with people who have returned from abroad within the last 14 days. Patients who have participated in meetings and events that attract more than 50 people indoors within the past 14 days. Patients with the chief complaint of dysgeusia should be interviewed for olfactory dysfunction and consider the possible initial symptom of infection posed by this. Number 3, even asymptomatic patients may infect others with the novel coronavirus and can be a source of infection. Number 4, it is important to thoroughly implement standard precaution in the medical treatment. Be sure to wash hands before and after patient-dentist interaction. Wearing PPE, including mask, gloves, goggles, face mask, gown, are basic requirements. Indoor ventilation and disinfection of open surface after hospital visits are important. Also, consider setting a time interval between visits to reduce airborne virus densities. Number 6, postpone recall for non-urgent outpatient. Number 7, consider methods to minimize aerosol generation and exposure when performing oral surgery and oral care. Number 8, consider postponing the surgery if you can determine that it's not urgent. Number 9, in elective surgery, ask the patient to refrain from going out, not attending events, or banning travel for the last 2 weeks before the surgery. Number 10, consider changing the treatment if there is a treatment alternative to surgery, a treatment with lower aerosol exposure. During the emergency declaration, we heard that many hospitals refrained from performing oral and maxillofacial surgery, and that caused us to investigate the execution rate of oral and maxillofacial surgery in each training hospital of JSOMS. Questionnaires were sent to 540 training facilities engaged in JSOMS. 64% of the facility answered between June 5th and 22nd. So, what was the execution rate of the hospital? During the emergency declaration, a total of 55%, answering hospital performed less than 25% of usual surgery at outpatient clinics. And 56% of answering hospital performed less than 25% of surgery, of usual surgery under general anesthesia here. And after the emergency declaration, 61% here of answering hospital performed more than 75% of usual surgery at outpatient, and 53% of answering hospital had more than 75% surgery under general anesthesia. And nowadays, most of hospital performed 80% of surgery, 80%, more than 80% of surgery compared to usual. Here we show idea for safe oral and maxillofacial surgery. First, PCR test plus chest CT before surgery is recommended. Although for various reasons, PCR tests in Japan are limited to 3 organizations: Ministry of Health, Labor and Welfare, National Institute of Infectious Disease, and Health Center and Regional Health Research Institute that decides who gets the PCR test in the new coronavirus measures. It is stipulated in the Infectious Disease Act that these organizations monopolize administrative tests, including PCR. Furthermore, we did not know the actual reliability of PCR, antigen or antibody tests, or how to select among them. Dental hygienist trying to remove patient tartar in full PPE because of fears of new corona infection caused by aerosol. What is the effectivity of aerosol generating surgery? On August 11, the World Health Organization pointed out the needs to protect patients and staff from new corona infection caused by aerosol particle in the air, because dental clinics are open in various places. But actually, no cluster occurred at dental clinic in Japan. There is no evidence about what must be done. What is the real situation, however, here? So, the Japanese Society of Oral and Maxillofacial Surgeons has made a public call for data of research in aerosol infection. Also, there are no guidelines for safely performing oral and maxillofacial surgery under COVID-19. So the task force of JSOMS has begun to develop guidelines now. This slide shows robotic-assisted surgery. This slide shows a remote clinical support system. The use of robotic-assisted surgery or remote clinical support system introduction may be accelerated in oral and maxillofacial surgery. This slide shows the measure for preventing COVID-19 outbreak in Japan. The Japanese government showed us a new lifestyle for preventing COVID-19. The new lifestyle is made up of 4 measures, such as basic infection prevention measure for each person, basic lifestyle in daily life, lifestyle for each aspect of daily life, new working style, wearing a mask, keeping a distance as with station chair, and line to cash register. We think the new lifestyle ideas are good for infection prevention, but those are not new lifestyle, just patience really. I'm really worried about the relationship between people which would be diminished. Professor Oshitani, a member of advisory board and expert organization of the Ministry of Health, Labor and Welfare say, I think it is time for us to seriously discuss how to think about the risks of this virus and how to manage the risks. It is necessary to reach a social consensus how seriously to deal with the risks. This photograph shows the beautiful season in Hokkaido University, spring, summer, fall, winter. Unfortunately, we cannot enjoy our campus with our students now. Thank you for your attention.
Yeah, thank you very much. Thank you very much, Professor T, for very nice presentation. So after COVID outbreak, I think most of the country, all of the world have the same problem because we're facing to the COVID virus. So, Professor, we have some question from the audience. So, would you mind to answer? So, I would like to read the question.
Okay.
Okay. Yeah. The first question is from Dr. Karima Mansur. So, actually, she graduated from Tokushima Daigaku.
Oh,
Dr.
really?
Karima, yeah. Yes.
Can he speak Japanese?
I think, but our system is the audience type the question.
Okay.
So, okay, I will read the question. Thank you for your interesting presentation. I would like to know how the master or PhD students continue their teaching or research.
Okay.
Do they have to pending it or just continue? Because as I know, some research plans cannot be canceled, especially if they are working with animal. So that's the first question, Professor, please.
Yes, you are right. For PhD student, the environment is not so good. So they postpone their research or some experiment. But in PhD they have 4 years, so I can manage. I think we can manage in 4 years, total 4 years. Thank you.
Yeah, thank you. Yeah, for 4 years, I think it's a long time for they manage their research.
Yeah.
Yeah. Thank you, Professor. So we still have a question.
Okay.
Yeah. From Dr. Susilawati. She is a lecturer in our institution, our Hasanuddin University. She asked about how about surgical patient who need face treatment while the PCR treatment need time to wait for the results. So please.
So the question is all the surgery patient need to do a PCR or not?
Yes, I mean, probably she asked about the emergency situation while a patient need to do a face treatment, but the doctor need or not to wait for the PCR results before the treatment, or yeah, maybe like that.
Yeah, actually, in Japan, PCR are limited. So most patients do not accept the PCR test before surgery.
Yeah.
So PCR test is need 1 day in Japan, in 1 day. So 1 day, most nowadays maybe 10 hours or 12 hours. Yeah. So before they enter the hospital, the day before surgery, they need to check the PCR and then enter the hospital. Yes. Thank you.
Okay. So the result of PCR it's about less than 1 day, maybe 12 hours.
Yes.
Okay. Thank you very much.
But most of the patient did not get the PCR because in Japan the PCR test is limited.
Is it covered by insurance, Professor? Is it
Not
covered by insurance?
covered by the government.
Oh, covered by government. Okay, I see. So, Professor, we still have a question. So, as I saw in your presentation, that there is some delay in the academic process.
Yep.
I mean, yeah. So, how could you manage the the delay? It's make the study duration longer for student. So how the university or the government manage the situation, because it will affect the length of study.
So I know it's a very difficult question.
I'm sorry.
It's a very difficult question. So our government instruct us to give flexibility to accreditation, but without nowadays student skill is not good and the knowledge is not so high. So, but we have a 1 year residence after they graduated. We have one year for residence. At that time, we can train again.
Okay. Yeah. Thank you very
and,
much.
Another, I think we need to, for the future, we need to make another system, that is virtual reality training. Virtual reality training is more needed. We can use virtual reality anytime.
Virtual reality training. Okay. Very nice information, Prof. So, Professor, we still have a question. Is it okay for answer? You still have a question from Priscilla, Dr. Priscilla. So she is a resident of oral maxillofacial surgery in UNHAS. She asks about what are the tricks and system if oral maxillofacial surgery work in phantom. What are the case and how are the mechanism? I mean, what case of resident of maxillofacial conduct in phantom? So maybe there is a sample of cases. What kind of case that they can use in phantom? For example, maybe pull the tooth or.
I can't hear you well. Please repeat again.
Okay. The question from Dr. Priscilia. So she is a resident of oral maxillofacial surgery. Yeah, she asked about that. What are the tricks and system if oral maxillofacial surgeon work in Phantom? I mean, maybe because she is a student, he's a resident. So she asked what kind of cases that she can conduct on Phantom.
Simulator. No simulator.
Yeah, no simulator, but in Phantom.
Phantom.
Yeah. Yes.
No Phantom. We have no training of Phantom. No. For patient.
Yeah.
To the patient. So now clinical training is prohibited in our hospitals. So I'm afraid our student skill it's very dangerous. Thank you.
Yeah, yeah. That's also the concern of Indonesian lecture, how to change the mechanism and work in patient and then change to the Phantom. So the psychomotoric difficult to evaluate. Yeah, I think thank you very much, Professor Tay, for very nice presentation today. So we have we learned from Japan how to deal with COVID-19. Okay, thank you very much, Professor Kanchu.
Thank you.
And yeah, we really hope that when the COVID gone, so you can come to Indonesia and then
thank you.
We can meet in Indonesia. Thank you very much, Prof.
Okay.
For very nice. So
Thank you.
have we have a certificate for you. So certificate will be given by our dean, Dr. Ruslin. So please show the certificate to organizing committee.
This is certificate for Professor Kanchu and say my big sensei. Again, thank you very much. We will send to you by email.
Okay.
Once
Thank
again,
you very
thank
much.
you very much. Domo arigatou gozaimashita.
Ruslin, thank you.
Wasa Indonesia no gakkai. Have your stay today. Arigatou gozaimashita.
Oh, nice Japanese.
Yeah, just a little.
So,
okay, thank you very much for
bye everyone. Bye.
Yeah, bye. Thank you very much. Okay, ladies and gentlemen, so we now move to another session, and I think Dr. Erlina Burhan also already joined with us. Ya, jadi Bapak Ibu sekalian, sesi berikutnya kita akan masuk ke materi yang akan dibawakan oleh Dr. Erlina. Assalamualaikum, Dok. Apakah suara saya bisa didengar dengan baik, Dok?
Jelas sekali.
Terima kasih banyak. Ya, terima kasih banyak, Dok, sudah saya sangat mengerti bahwa waktu Dr. Erlina ini sangat sempit sekali, apalagi terkait dengan kesibukan yang sekarang. Ya, jadi sebelum saya mempersilahkan kepada Dr. Erlina untuk menyampaikan materi pada pagi hari ini, saya akan membacakan beberapa CV tentang beliau. Jadi beliau adalah Dr. Erlina Burhan, M.Sc, Ph.D, Pulmonologist Consultant. Beliau telah menjadi seorang pulmonologis selama lebih dari 16 tahun. Kemudian beliau banyak fokus ke tuberkulosis, penelitian tentang TB. Kemudian ya, saya kira kita sudah sering melihat Dr. Erlina di TV-TV nasional menyampaikan beberapa hal terkait dengan kondisi-kondisi COVID-19. Jadi disampaikan juga berdasarkan kondisi sekarang yang ada di negara kita. Jadi Dr. Erlina sebagai ketua gugus COVID di Rumah Sakit Persahabatan, ya beliau. Jadi saya kira beliau sangat expert dan master dalam hal terkait materi yang akan beliau bawakan. Untuk Bapak Ibu yang sebagai peserta, jika ada pertanyaan yang akan disampaikan oleh Ibu Erlina kepada Ibu Erlina, setelah sesi presentasi dipersilahkan untuk mengetik pertanyaan melalui kolom question and answer yang ada di Zoom. Baik, saya kira seperti itu untuk menghemat waktu. Saya persilakan kepada Dr. Erlina Burhan untuk menyampaikan kepada kita terkait materi. Silakan, Dokter.
Ya. Apakah terlihat dengan jelas?
Ya, terlihat, Dokter. Baik.
Oke, suara juga jelas ya?
Ya.
Jelas, Dokter.
Oke, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Pertama,
Waalaikumsalam.
Selamat kepada Fakultas Kedokteran Gigi UNHAS nih yang sudah berhasil membuat tadi pembicara asingnya banyak sekali ya. Jadi tapi ini saya bahasa Inggris apa bahasa Indonesia ini?
Bahasa Indonesia aja, Prof.
Bahasa Indonesia aja. Oke ya. Ini terima kasih nih diundang untuk bicara tentang bagaimana tata laksana COVID dan dalam usaha menuju normal. Ya, ini saya sedikit dulu ya menyampaikan sebagai background bahwa COVID ini disebabkan oleh virus namanya SARS-CoV-2 dan ini menjadi mulai begitu ada laporan dari Cina Desember 2019 dan kemudian diumumkan oleh WHO menjadi pandemi. Kasus sejak itu makin meningkat ya. 250 negara sekarang sudah melaporkan kasusnya dan Indonesia termasuk salah satunya yang kasusnya terus meningkat. Walaupun ya untuk COVID ini 80% itu adalah dengan gejala yang ringan bahkan tanpa gejala. Namun 15% kasusnya ada perlu perawatan jadi moderate dan severe dan 5% diantaranya kemudian menjadi kasus yang critically ill dan 2-3% diantaranya meninggal dunia. Kecil hanya 5% yang kritis, 2-3% meninggal. Tapi kalau itu didapatkan dari sekelompok orang sakit yang jumlahnya banyak, nah ini akan menjadi banyak jadinya. Oke, dan yang menjadi permasalahan sekarang adalah bahwa hingga saat ini ada obat yang spesifik untuk COVID. Jadi kalau ada yang mengatakan menemukan obat itu mungkin harus klarifikasi ya. Juga kalau ada yang mengatakan vaksin sampai saat ini belum ada. Memang ada ratusan yang dalam pipeline, dan bahkan ada beberapa kandidat yang sampai 40 kandidat itu berpotensi untuk menjadi vaksin yang efektif. Saat ini 5 diantaranya sudah mulai uji coba ke fase 3. Salah satunya di Indonesia ya yang Sinovac vaksin, walaupun Lembaga Eijkman sekarang juga sedang mengembangkan vaksin namanya vaksin merah putih. Nah, jadi kita tunggu efektivitas dari vaksin ini. Mudah-mudahan bagus sehingga kemungkinan kita akan kasusnya menurun. Ya, saya ingin menyampaikan juga bahwa kalau dulu kita tahu SARS-CoV-2 ini targetnya umumnya adalah dimulai hidung sampai ke saluran pernafasan. Ternyata banyak sekali organ-organ yang bisa diinfeksi oleh SARS-CoV-2 ini, mulai dari saluran cerna, jantung, mata, lever, ya, ginjal, pankreas, karena ibunya positif. Ya, dan yang juga perlu kita waspadai adalah bila mana kasusnya menjadi berat, maka akan terjadi apa yang disebut dengan cytokine storm. Cytokine storm itu adalah kondisi di mana terjadi badai sitokin. Sitokin ini adalah perangkat imunitas yang menabuh genderang istilahnya, atau memberi sinyal pada sitokin antiinflamasi untuk datang mengatasi inflamasi yang ada. Tapi sayangnya pada COVID kadang-kadang ini terjadi tidak terkendali sehingga sitokin itu banyak sekali, makanya disebut badai, dan karena banyak sekali juga memberikan sinyal yang banyak sehingga sitokin pro-inflamasinya juga banyak yang datang ke daerah infeksi, dan ini justru akan merusak lokasi di sekitarnya, dan ini malah berbahaya, dan inilah yang biasanya menimbulkan kerusakan multi organ, organ failure, dan akhirnya meninggal. Ya, ini saya sedikit bicara tentang timeline ya, bahwa Indonesia waktu itu kasus pertama adalah 2 Maret ya, kemudian terus terjadi kasus, maka sekitar April pemerintah membuat satuan tugas atau satgas COVID-19 ya, dan juga di akhir April membuat ketentuan tentang PSBB ya, jadi pembatasan berskala besar waktu itu ya, pembatasan sosial berskala besar. Namun kita juga tahu ternyata banyak orang tidak patuh ya, di Jakarta bahkan juga hanya 70% orang yang pakai masker ya, 30% masih abai ya. Oh ya, kita lihat juga ini di sini sudah lebih dari 2 juta spesimen yang diperiksa, dan saat ini Indonesia kasusnya adalah di atas 160.000 dengan kematian hampir 7.000 ya. Ini kematian yang cukup tinggi ya, dikatakan ini 4,3%. Ya, fasilitas di Indonesia seperti apa? Dulu waktu bulan Maret kita ingat bahwa laboratoriumnya sangat sedikit, hanya 1 pertama kali, kemudian berkembang jadi 12 ya. April menjadi 48 laboratorium yang bisa melaksanakan pemeriksaan PCR. Sampai Juli ini dikatakan ada 246 laboratorium. Jadi ini sesungguhnya sesuatu yang menggembirakan bahwa kapasitas pemeriksaan Indonesia terus bertambah. Demikian juga dengan rumah sakit rujukan. Sampai 11 Maret hanya 132 rumah sakit rujukan dengan fasilitas yang berbeda ya. Ada yang sangat lengkap, ada yang seadanya ya. Kemudian angka terus bertambah. Per 24 Agustus ini ada 140 rumah sakit rujukan. Ya, ini saya ingin sampaikan bahwa beberapa hal yang penting yang saat ini dilakukan oleh pemerintah adalah 3T. Mohon diingat ya, 3T yaitu tracing, testing, and treating. Dan mungkin juga PSBB, large scale social limitation, ini mulai dari work from home, bekerja dari rumah, sekolah ditutup, semua orang memakai masker, untuk akses ke public area itu dibatasi, bahkan juga kegiatan keagamaan juga dibatasi, kegiatan-kegiatan sosial budaya direstriksi, kemudian juga transportasi juga pernah dibatasi dan lain-lain ya. Tapi sekarang sudah relaksasi PSBB dan kita lihat sekarang semua orang menuju new normal, tapi sayangnya masih mengerti dengan new normal. Banyak menganggap bahwa normal, bukan new normal. Harusnya normal kegiatannya, tetapi budaya baru. New itu adalah adaptasi kebiasaan baru atau kebudayaan baru, atau mungkin peradaban baru ya, di mana sekarang jarak ya agak-agak susah untuk saat masa sisi ini, karena itu kan sosial, senangnya bersosial, berinteraksi, tapi dengan adanya pandemi ini kita harus berubah. Ya, ini PSBB yang dilaksanakan di Indonesia bahwa membatasi keramaian, dibuka, ditutup sekolah dan kantor-kantor walaupun sekarang sudah dibuka ya, yang hanya boleh saat PSBB ketat waktu adalah supermarket, fasilitas kesehatan yang dibuka, fasilitas finansial seperti bank, ATM dan lain-lain juga hal-hal yang penting untuk keseharian seperti pom bensin dan lain-lain. Ya, ini ada beberapa provinsi yang melaksanakan restriction yang segera ya. Jakarta, Sumatera Barat, Gorontalo, Jawa Barat, dan ya Makassar juga ada di sini. Makassar mulai 24 April ya. Dan yang beberapa kota ini baru mulai di bulan Mei ya, agak-agak terlambat sepertinya. Ya, bahkan sekarang karena melihat PSBB ini tidak dan juga adaptasi kebiasaan baru ini tidak dilaksanakan dengan sebagaimana mestinya, maka akhirnya Presiden mengeluarkan Inpres ya yang 4 Agustus 2020 itu meminta kepada Pemda atau kepala daerah untuk mengeluarkan aturan-aturan pelaksanaan adaptasi kehidupan baru dan memberikan sanksi bila itu tidak dilaksanakan. Tapi aturan dan sanksinya diserahkan kepada daerah masing-masing. Ya, jadi saya tadi mengatakan ini ada beberapa kegiatan yang mesti dievaluasi mulai dari testing. Nah ini pemeriksaan di Indonesia saat ini positivity rate-nya di atas 13%, padahal kalau dikatakan pandemi itu terkendali harusnya di bawah 5% ya. Demikian juga untuk evaluasi, banyak yang kasus-kasus tidak bisa di-trace, tidak bisa di-tracing, sehingga ini akan terus menjadi sumber penularan untuk orang lain ya. Demikian juga untuk isolasi, ini banyak yang disobey, banyak yang tidak patuh. Ya, jadi walaupun dari fasilitas kesehatan dikatakan, ayo Bapak ini positif, Ibu positif, isolasi diri di rumah ya, tapi karena banyak yang merasa tidak ada gejala masih keluar rumah saja. Ini suatu perbuatan yang tidak boleh dalam situasi kasus Indonesia masih meningkat seperti saat ini. Ya, jadi sedikit menyampaikan bahwa penyebaran COVID-19 ini adalah yang langsung dari direct transmission, yaitu dari droplet yang keluar pada saat seseorang batuk, bersin, atau bahkan berbicara dalam waktu lebih dari 15 menit, ya, itu memungkinkan terjadi droplet yang berisi partikel virus. Ya. Kemudian juga ada transmisi yang tidak langsung, yaitu melalui benda-benda permukaan, benda-benda mati yang terkontaminasi. Contohnya adalah meja, kursi, atau mungkin juga alat-alat di tempat praktek ya, termasuk alat-alat di tempat praktek teman-teman sejawat dokter gigi. Dan demikian juga salah satu yang sekarang kita khawatirkan adalah tindakan-tindakan yang menimbulkan aerosol. Jadi ada medical procedure yang banyak menimbulkan aerosol. Kalau di bidang saya dokter paru adalah tindakan bronkoskopi. Nah, tapi pada teman-teman gigi mungkin lebih banyak lagi ya, banyak sekali prosedur yang menimbulkan aerosol. Ini bukan saja berbahaya untuk orang sekitar di dalam ruangan, justru dokter ini dalam risiko tinggi kalau pencegahan penanggulangan infeksinya tidak dilaksanakan atau APD-nya kurang sesuai ya. Ya, ini kita lihat ini rute transmisi di tempat praktek dokter gigi, barangkali teman-teman jauh lebih mengerti dari saya ya. Jadi pasien-pasien yang terinfeksi yang barangkali teman-teman sejawat tidak tahu bahwa sebetulnya pasien itu adalah positif tapi tidak ada gejala atau OTG disebutnya ya, datang ke praktek Anda dan kemudian prosedur tindakan akan menghasilkan droplet atau aerosol. Nah ini sangat berbahaya ya untuk ruangan tersebut terkontaminasi, juga alat-alat terkontaminasi, dan tentu saja ujung-ujungnya kalau ini tidak ketat diatasi maka justru dental profesional yang akan menanggung risikonya, apakah itu dokternya atau perawatnya atau yang lain-lain. Ya, sedikit ingin saya sampaikan gejala dari COVID ini. Ya, gejala yang sangat khas adalah demam. Jadi mohon nanti ditanyakan pasiennya apakah ada demam, ya, kemudian ada batuk, rasa lemas, tidak ada nafsu makan, kadang-kadang sesak, ya, sakit kepala, bisa diare, bisa nyeri tenggorok, atau sumbatan di hidung, atau sekarang yang cukup banyak ditemukan adalah anosmia. Jadi artinya ada masalah dengan membaui sesuatu. Jadi penurunan kemampuan untuk membaui sesuatu, ya. Kemudian juga ada penurunan kemampuan untuk merasakan makanan atau agesia, ya. Jadi, ada sekarang virusnya sudah juga menyerang organ lain, jadi bisa otak, sehingga gejala klinisnya bisa seperti orang stroke yang mungkin kejang dan lain-lain. Kemudian juga di mata bisa menimbulkan kemerahan di mata karena ada juga inflamasi kornea, ya, atau di saluran pencernaan ada diare, saya sudah sebutkan tadi. Ada juga akut kidney injury, ya, di ginjal juga terjadi infeksi, protein urea, jadi di urinnya terdapat protein. Kemudian juga bahkan di sistem persarafan pusat itu ada kejang, ada kesadaran menurun, dan juga tadi kita lihat di pankreas, jadi bisa saja manifestasinya tiba-tiba gulanya naik, ya. Kemudian juga di kardiovaskuler, ini juga penting, bahwa ini juga merusak sistem kardiovaskuler, terdapat trombosis, ya, kemudian menimbulkan penyempitan saluran pembuluh darah, sehingga kejadian hipertensi sering terjadi pada pasien COVID. Jadi apalagi kalau ada komorbid hipertensi, maka tensi akan lebih tinggi lagi. Pada orang normal saja, kalau yang diserang adalah pembuluh darah, itu akan menimbulkan hipertensi juga. Jadi mohon diperhatikan, jangan, masyarakat sering mengatakan, orang tua saya datang dengan stroke, kenapa dibilang COVID? Orang tua saya sakitnya diabetes, orang tua saya sakitnya hipertensi, kenapa sampai di rumah sakit dikatakan COVID? Ya memang COVID ini adalah penyakit 1000 wajah, ya, bisa dengan gejala klinis yang bermacam-macam saat ini. Jadi memang pengetahuan kita bertambah terus karena COVID ini, ya, karena banyak sekali yang kita pelajari, yang terus ada perkembangannya, bahkan sekarang juga ada happy hypoxia. Jadi walaupun pasiennya kekurangan oksigen, tapi pasiennya terlihat biasa-biasa saja. Ya, ini ada beberapa perubahan untuk definisi kasus COVID, ya. Kalau dulu kita mengenal PDP, ODP, sekarang nggak ada lagi. Yang sekarang mereka disebut dengan suspek, ya. Jadi orang yang dengan gejala, ya, atau orang yang dengan riwayat kontak, atau pasien dengan gejala saluran nafas dan ada pneumonia, ini suspek. Kemudian ada juga probable. Probable ini adalah betul-betul persis keluhannya seperti COVID, bahkan terjadi ARDS atau gangguan organ, tetapi kemudian hasil pemeriksaan PCR-nya tidak ada. Nah, ini kalau kemudian pasiennya meninggal dianggap sebagai probable, ya, walaupun tidak ada hasil PCR-nya. Dan yang terakhir yang semua kita tahu adalah definisi untuk confirm atau positif, yaitu pasien yang secara laboratorium PCR ini hasilnya menyatakan positif. Jadi gold standarnya adalah PCR, bukan rapid test, ya. Oke, nah ini ada beberapa, kita lihat pembagian dari severity atau gejala klinis. Ada yang ringan, saya sampaikan tadi, ya, ringan, itu gejalanya demam, batuk, nyeri tenggorok, Malaysia, ya, tidak ada komorbid, anosmia atau gangguan penciuman ya. Dan juga ada yang moderate. Moderate itu biasanya ada pneumonia, batuk terus-menerus ya, kemudian disertai sesak. Dan yang berat adalah bila nafasnya dari 30 kali per menit ya, kemudian saturasi oksigennya sudah terus menurun sampai bahkan di bawah 90. Ya. Diagnosisnya tentu saja mulai dari anamnesis, kita lihat simptomnya, riwayat kontaknya, riwayat perjalanan, pemeriksaan darah rutin, pemeriksaan RT-PCR ya. PCR ini adalah gold standar. Kemudian juga dilihat radiologinya, apakah terdapat pneumonia di ronsen torak atau di CT scan terlihat ground glass opacity, jadi pemadatan di bawah ya. Ya, ini kita lihat ini ya. Kalau secara foto toraks terlihat ini gambaran konsolidasi di paru ya. Biasanya kiri kanan ya. Ini saya ambil dari foto-foto pasien yang dirawat, jadi kiri kanan biasanya karena memang luas ya. Dan ini CT scan-nya ya, gambaran ground glass opacity ini ya. Ya, ini kita lihat. Ya. Jadi sekarang kalau ditanyakan spesimen mana yang memberikan nilai positif yang paling tinggi, tentu saja dari tindakan bronkoskopi itu diambil BAL ya, bronchoalveolar lavage 53%, ya. Kemudian kalau dari dahak 72%, dari swab tenggorok kepositifan 63%, dari swab hidung ya 63%, swab tenggorok 32%, makanya dilakukan biasanya 2 kali hidung dan nasal supaya kepositifannya bertambah ya, bisa sampai lebih dari 90%. Kalau dari feces juga ada, hanya 29%, dari darah 1%, dan tidak ada yang positif dari urin. Ya, ini tentang rapid test, ini karena banyak orang yang bertanya tentang rapid test. Kita lihat rapid test ini bukan mendeteksi virus, tapi mendeteksi antibody. Ada 2 antibody, yaitu IgM dan IgG. IgM ini baru terbentuk kalau sudah ada gejala, itu biasanya setelah hari ke-7 ya, ini IgM. Dan kemudian IgG terbentuk kalau sudah hampir hari ke-14, dan biasanya IgG ini akan bertahan lama ya, bisa 3 bulan sampai 12 bulan, makanya diharapkan kalau IgG-nya bertahan terus, artinya apa? Artinya sudah ada antibody yang memberikan kekebalan kepada pasien. Ya, jadi justru kalau rapid test positif IgG-nya dan tidak ada gejala, harusnya tidak usah panik, karena itu artinya pernah terpapar dan sekarang sudah ada antibody di dalam tubuhnya. Ya, oke. Ya, ini saya ingin membandingkan atau memberikan gambaran mengapa rapid test itu tidak merupakan pemeriksaan untuk diagnosis, karena harus dibandingkan dengan, harus dikonfirmasi dengan PCR. Jadi kalau PCR-nya positif, rapid test dua-duanya negatif, kemungkinan ini masih window period. Jadi masih masa inkubasi, belum ada gejala. Tetapi kalau rapid test-nya IgM-nya positif, ya maka ini menunjukkan bahwa baru mulai timbul gejala, ini penyakitnya masih early stage ya. Dan kalau ketiga-tiganya ini positif, menunjukkan ini pasien dalam kondisi sangat aktif, sangat menular. Nah, bagaimana kalau PCR positif, IgM negatif, IgG juga positif, ini biasanya sudah late stage, barangkali sudah fase recovery, ya, dan seterusnya. Oke, nah kenapa rapid test tidak dipakai untuk diagnostik? Karena itu yang seperti yang saya terangkan tadi, dan WHO sebetulnya menganjurkan rapid test ini untuk survei epidemiologi atau untuk survei kebutuhan, ingin melihat berapa banyak masyarakat, berapa persen yang sudah terpapar ya. Dan untuk rapid test ini banyak false positif karena ada cross reaksi dengan kuman lain atau virus lain, dan juga bila mana ada rheumatoid factor juga bisa positif. Jadi makanya selalu dikonfirmasi dengan PCR. Mungkin juga kalau false negatif, ini mungkin saja belum ada gejala, tapi memang sudah COVID-nya positif tapi belum ada gejala, atau mungkin dalam jumlah cukup dideteksi. Ya, bagaimana pengobatannya kita bagi dengan pasien positif atau terkonfirmasi ya, tapi tidak ada gejala, maka cukup isolasi diri di rumah, diberikan edukasi apa yang harus dilakukan, mendapat vitamin C, diminta mengukur suhu 2 kali sehari ya, dan pasien harus bisa dimonitor oleh petugas kesehatan dan kemudian kontrol ke vaskes 14 hari kemudian. Nah, kalau yang ringan ini juga karena sekarang rumah sakit cenderung penuh, maka yang ringan ini sebaiknya bisa diisolasi di rumah ya. Tapi selain mendapat vitamin, ada mendapat obat-obatan seperti azitromisin 1 kali 500, kemudian bila diperlukan bisa mendapat antivirus, yaitu oseltamivir atau favipiravir, ini Avigan ya. Dan juga setelah 14 hari kontrol ke fasilitas kesehatan. Bagaimana yang moderate? Moderate ini harus dirawat. Ya, harus dirawat. Obat-obatnya sama, tapi sebagian diberikan secara intravena, ya, mendapat vitamin C, kloroquine, azitromisin, dan antivirus, ya. Demikian juga yang berat. Yang berat ini biasanya ada komorbid, terjadi kerusakan organ lain, maka perlu obat-obat suportif selain obat-obat yang standar of care tadi ya, yang vitamin C, kloroquine, azitromisin, antivirus, oseltamivir, favipiravir, atau mungkin juga bisa diberikan sekarang obat yang baru masuk ke Indonesia itu remdesivir ya. Dan atasi existing comorbid ya, juga monitor secara ketat. Ya, jadi kesimpulannya standar of care untuk COVID di Indonesia itu adalah azitromisin, kloroquine, vitamin C, antivirus bisa dipilih apakah oseltamivir, Avigan, remdesivir, atau Aluvia ya, ini lopinavir plus ritonavir ini sebetulnya adalah obat HIV ya. Tetapi ada option lain kalau pasiennya berat bisa sekarang adalah sedang dikembangkan tapi ini masih dalam uji klinis, yaitu pemberian stem cell, plasma konvalesen, penghambat interleukin 6 yaitu tocilizumab, penghambat interleukin 1, interferon, human immunoglobulin, dan imunomodulator lainnya, dan juga steroid ya. Bagaimana kriteria isolasi? Sudah selesai. Untuk yang tidak bergejala, cukup setelah 10 hari setelah hasil positif. Tapi untuk yang pasien-pasien yang ada gejala, maka butuh 10 hari ditambah minimal 3 hari tanpa gejala ya. Dan untuk yang berat biasanya diperlukan pemeriksaan RT-PCR 1 kali negatif. Ya, bagaimana pasien ini kita bisa keluarkan dari ruang isolasi, yaitu tadi 10 hari plus 3 ya. Jadi kalau pasien baru 2 hari, hitung 10 hari setelah gejala, tambah 3, jadi 13 hari kemudian bisa keluar dari ruang isolasi dan seterusnya. Ya, tapi ingat yang penting sebetulnya adalah prevention ya. Prevention, jangan keluar rumah kalau nggak perlu. Jaga jarak 1 meter minimal, hindari keramaian, cuci tangan, bersihkan benda-benda di sekitar kita, permukaannya dengan desinfektan, ini buat dokter gigi sangat penting ya. Lakukan regular aktivitas yang biasa, kemudian boleh mengkonsumsi suplemen, makan makanan sehat, dan cukup istirahat. Ya, jadi, nah ini untuk dental care, ini risiko ada dibagi nih menurut Occupational Safety and Health Administration USA ya, ada yang lower risk, medium, high, dan very high. Nah, saya kira healthcare worker termasuk dentist ini kalau pekerjaannya menimbulkan aerosol generating ini bisa dianggap high risk sampai very high ya. Ya, ini fasilitas di dental healthcare facility ya, secara during pandemi ini mestinya ada membuat triase ya, prosedur, lakukan pre-screen pasien sebelum memasuki fasilitas dental. Kemudian juga seharusnya pasien tidak diperbolehkan datang walk-in begitu ya, tapi sebaiknya dengan appointment supaya kita bisa mengatur hari ini karena pasien masih dibatasi. karena kita tidak mau pasien antri terlalu lama dan ramai sekali ya. Kemudian pastikan ada jaga jarak di tempat ruang tunggu, hand hygiene ini pasti harus. Kemudian juga PPI-nya ya, pencegahan pengendalian infeksi dijalankan, dan juga sistem ventilasi ruangan harus dipastikan ventilasinya bagus ya, dan infection control-nya juga oke, dan edukasi untuk pencegahan juga harus ada dilakukan di fasilitas kesehatan gigi. Ya, ini di triase semestinya adalah ada pre-screen untuk pasien, diperiksa suhunya, kemudian ditanyakan riwayat kontak, dan ditanyakan tentang simptom atau gejala atau apakah ada keluhan atau tidak ya. Ini adalah di triase atau pre-screen area ya, sebelum memasuki fasilitas gigi. Ya, ini di ruang tunggu harusnya seperti ini, tidak boleh banyak-banyak, makanya pasien itu harus by appointment ya, jangan tidak ada appointment, datang kadang-kadang datang dengan keluarga dan itu akan ramai sekali, itu nggak boleh ya. Demikian juga personal protection equipment atau PPI-nya harus lengkap ya, mulai dari surgical mask, eye protection atau apakah itu Google atau face shield ya. Sorry ini salah ketik. Kemudian pakai gaun, ya, pakai sarung tangan, dan bila mana tindakan itu seperti rata-rata dokter gigi itu adalah aerosol generating, maka harus memakai N95 ya, dan juga tata cara yang lainnya, terutama tata cara membuka masker, membuka face shield, membuka gaun dan lain itu juga harus diperhatikan. Ya, ini hanya beberapa contoh ya, gaun yang bisa dipakai, pakai face shield dan di dalam pakai masker. Saya kira semua dokter gigi pasti begini ya. Ya, kemudian juga pengendalian yang sifatnya engineering. Jadi artinya ruangannya bila memungkinkan ada negative pressure, bila tidak maka pakai HEPA filter ya, agar supaya airborne infection itu bisa dikendalikan, dan atau aerosol generatingnya itu bisa teratasi kalau ada negative pressure atau ada HEPA filter. Ya, dan juga untuk pengendalian infeksi lingkungan harus dilakukan cleaning rutin dan membersihkan benda-benda dengan desinfektan ya, dan sterilization procedure ya. Jadi kalau semua prosedur pencegahan itu dilakukan, maka mudah-mudahan Indonesia bisa mencapai tujuannya ya, adalah membuat kurva ini landai ya. Karena kita sekarang masih naik puncak gunung. Kita belum tahu puncak di mana. Ya, tapi kalau prevention dilakukan dengan baik, maka ini akan terus ke bawah dan melandai. Kalau situasi sudah landai, artinya bahwa kita sudah terlepas dari pandemi ya. Saya kira demikian presentasi dari saya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Saya kembalikan kepada moderator.
Baik, terima kasih banyak Dr. Erlina, presentasinya sangat menarik sekali dan sangat merefresh lagi, dan banyak ilmu-ilmu yang baru terkait dengan COVID yang baru saja disampaikan oleh Dr. Erlina. Ya, memang situasi sekarang ini selain memberikan disaster dari kita, juga mengajarkan kita untuk lebih bersikap lebih bersih. Nah, seperti tadi yang disampaikan bahwa new normal, bahwa kehidupannya kita tetap seperti biasa, tetapi kebiasaannya yang harus baru. Nah, itu tadi yang disampaikan oleh Dr. Erlina, sangat menarik sekali, Dok. Kemudian, Dokter, ini ada beberapa pertanyaan dari audiens. Ya.
Tolong dibacakan saja.
Ya, mohon izin Dok, saya bacakan. Ini ada, ya kebetulan pertanyaannya sama, ada dua penanya dari Dr. Airi dengan Dr. Handri. Mereka mempertanyakan mengenai happy hypoxia. Tadi dokter juga sudah sedikit menyampaikan. Mungkin bisa lebih detail lagi dok, dijelaskan mengenai happy hipoksia yang pasien tidak bergejala.
Iya, jadi happy hipoksia kondisi di mana pasien itu sebetulnya mengalami hipoksia. Hipoksia itu artinya saturasi oksigen atau tekanan oksigen dalam darahnya sudah menurun sampai di bawah 80 begitu ya. Normal manusia itu di atas 95% saturasi oksigennya. Tapi ada pasien yang kondisinya sudah sangat-sangat turun saat kita ukur, tapi pasiennya masih biasa saja. Masih menulis, masih main telepon, HP, bicara dengan keluarga, bahkan bawa laptop, masih mengetik di laptop, dan kalau pas dokternya visit masih ngobrol, tidak terlihat sesak. Nah, itu kenapa terjadi? Sebetulnya pastinya tidak, tapi ada teori mengatakan, jadi pada kondisi pasien yang mengalami cytokine storm, inflamasinya cukup luas, ini juga terjadi inflamasi ke lokasi yang seharusnya organ yang seharusnya memberikan sinyal, ya. Jadi persarafan ke sinyal ke otak. Jadi biasanya dalam kondisi normal, kalau seseorang kekurangan oksigen, maka ada sinyal ke otak, lalu dari sentral akan memerintahkan orang tersebut untuk bernafas lebih cepat, untuk mencari mendapatkan oksigen yang cukup. Jadi terlihat tersengal-sengal, sesak. Tetapi karena jalur ini rusak, terhambat, ada blocking karena cytokine storm, sehingga otak mendapatkan perintah untuk mengatasi kekurangan oksigen. Jadi pasien juga tidak memperlihatkan gejala seperti gasping atau bernafas cepat, tapi malah bisa melakukan, bisa ke kamar mandi bahkan ya. Tapi itu kejadian penurunan oksigen itu, hipoksia itu akan terus berlangsung pelan-pelan dan kemudian tiba-tiba sampai satu sisi. Jadi kalau hipoksia, kekurangan oksigen, darah itu terus diedarkan kan oleh jantung dan organ-organ tidak mendapat oksigen yang cukup. Nah, bila mana pada satu ketika itu sudah tidak bisa ada kompensasi dari tubuh, maka biasanya kesadaran menurun, terjadi kerusakan organ-organ di tubuh dan menimbulkan kematian. Itulah yang menimbulkan kejadian banyak orang mengatakan, oh dia nggak apa-apa kok, masih happy, gembira, ngobrol. Ya, padahal sesungguhnya kondisi objektifnya mengatakan lain, saturasi oksigennya sudah. Pengalaman di rumah sakit, saat diperiksa saturasi sudah 70, mandi. Biasanya kita memberikan terapi yang cepat, oksigen yang banyak, dan kalau perlu diintubasi pakai ventilator. Ya.
Iya, terima kasih banyak dok, penjelasannya sangat menarik sekali. Nah memang hipoksia ini apa namanya, semacam silent killer mungkin ya dok ya. Jadi secara klinis.
Betul. Ada istilah mengatakan silent killer, karena nggak ketahuan ya. Dan itu juga kebetulan ketemunya waktu itu kalau saya nggak salah di Inggris ya, di UK. Jadi pasien biasa-biasa saja, masih teleponan di rumah, tapi terus dipantau, begitu diperiksa oksigennya rendah sekali, langsung dilarikan ke rumah sakit, intubasi tapi meninggal ya. Jadi kemudian dikatakan, oh ini silent hypoxia. Tadinya disebut silent hypoxia, tapi begitu diubah jadi happy hypoxia, lebih sensasional kedengarannya, jadi orang lebih memperhatikan gitu ya. Ya, kita kan senang yang sensasi ya.
Iya, yang sensasi yang laku dok biasanya.
Apalagi media ya. Oke, ini ada pertanyaan nih, saya baca ya.
Iya boleh dok, silakan.
Apakah dapat sebagai media transmisi? Bisa, jawabannya bisa. Jadi saliva itu bisa menjadi media transmisi. Itulah makanya kita harus pakai masker. Kan sering tuh kita berteman-teman ngobrol, kalau dulu kan jadi bahan bercandaan. Wah ini ada hujan lokal. Nah kalau sekarang nggak boleh itu ya, karena ada partikel virus di situ. Dan kita nggak tahu, orang-orang banyak yang OTG sekarang. Itulah makanya wajib pakai masker, itu melindungi orang lain gitu. Dan kita, kalau kita semua pakai masker, kita itu saling melindungi. Dan sekarang berhubungan dengan saliva juga, saya ingin menyampaikan bahwa sekarang ini sedang diteliti untuk diagnostik itu nggak disuap lagi, tapi diperiksa dengan saliva saja. Sedang dikembangkan di Jepang, Korea, dan Amerika kalau saya tidak salah. Nah, mungkin nanti juga barangkali ada Prof. Nasrun, Wakil Rektor, bisa perintahkan anak buahnya di FK untuk meneliti saliva ya.
Ya, sebagai identifikasi COVID selain dari swab, jadi mungkin bisa lebih nyaman mungkin dok ya. Kalau swab kan mungkin rasa-rasa ada kayak gimana pada saat di swab. Kalau saliva mungkin bisa lebih praktis. Ya.
Ya, ini ada pertanyaan lagi ini. Ada kasus anak umur 2 tahun dites rapid hasilnya reaktif, sedangkan orang tua dan sekelilingnya non reaktif. Ya, jadi kalau saran saya sebaiknya dilakukan swab untuk memastikan apakah anak ini COVID atau bukan. Ya, karena saya sudah sampaikan tadi bahwa rapid test itu bukan untuk diagnostik. Ya, jadi artinya anak itu punya antibodi, ya, tapi harus dipastikan apakah ini sedang aktif sakit atau reaktifnya karena virus yang lain. Nah, jadi salah satu yang paling penting adalah pemeriksaan PCR, dan juga orang tuanya saya kira juga perlu diperiksa ya, dan orang sekelilingnya. Dan khusus untuk anak ternyata banyak penelitian mengatakan anak ini adalah silent spreader, jadi bisa menularkan ke banyak orang, sementara anaknya sendiri tidak bergejala kadang-kadang, ya. Jadi saya kira untuk Ibu Mardiana nih, tolong dipastikan anak yang umur 2 tahun ini diperiksa PCR ya. Ya, ini ada pertanyaan, seberapa efektif masker kain untuk mencegah penularan COVID? Jadi kan masker kain ini tujuannya adalah menghambat partikel virus yang terbawa oleh droplet, oleh apa namanya percikan ya, percikan yang keluar dari mulut atau hidung. Nah, jadi ini cukup efektif ya. Tapi memang masker kain ini nggak bisa dipakai terus-terusan. Paling lama 3 jam harus ganti. Ya. Apalagi kalau sudah basah wajib diganti.
Kalau yang ini dok, yang masker kain itu ada nggak? Mungkin lapisan-lapisan tertentu yang harus dimiliki supaya setidaknya untuk menfiltrasi mencegah penularan gitu ya.
Memang tidak sebagus masker bedah, kan, tetapi memang kalau 250 juta rakyat Indonesia pakai masker bedah nggak akan bisa tersedia. Jadi makanya karena ini disamaratakan, boleh memakai masker kain karena memang cukup efektif untuk mencegah partikel virus ke udara terbuka.
Iya. Ini masih ada dok pertanyaan di.
Prof. Mansur ini, Prof. Mansur, saya harus jawab nih, nanya. Kami tinggal di lantai 3, klinik gigi di lantai 1. Apakah bisa buka praktek? Ada pengaruh airborne? Ya, saya kira ini Prof. Mansur nanyakan amankah di lantai 3 karena di lantai 1 ada praktek gigi. Ya. Pertanyaan saya, kalau protokol kesehatan dijalankan dan tata cara pengendalian pencegahan infeksi dilaksanakan dengan baik, maka saya kira resikonya akan rendah. Jadi Prof. Mansur bisa bolak-balik lewat lift ya, sampai ke lantai 1 nggak masalah, Prof. Tapi itu tadi syaratnya protokol kesehatan dijalankan dan protokol PPI, pencegahan pengendalian infeksi, juga dilaksanakan. Ya, demikian.
Ya, ini ada pertanyaan di fasilitas Q&A, dok.
Ya.
Terkait dengan materi. Saya bacakan dok atau gimana?
Ya, boleh silakan.
Ya, ini pertanyaan dari dok Octavianus. Ingin bertanya tentang vaksin yang sedang diuji cobakan saat ini. Apakah bila uji coba vaksin ini berhasil, kita sebagai tenaga kesehatan tetap melakukan kegiatan di fasilitas kesehatan dengan baju hazmat
Oke,
kembali
ya.
atau ya?
Saya jawab, saya udah baca barusan. Ya, jadi kalau vaksin yang sedang kita uji coba ini berhasil, jadi dikatakan kalau keberhasilannya di atas 50% itu akan di-approve ya. Dan kalau ini terjadi, maka kabar gembira untuk tenaga kesehatan bahwa tenaga kesehatan, tenaga medis adalah kelompok yang mendapat prioritas utama, yang pertama untuk divaksin, ya. Kemudian baru yang lainnya, ya. Dan tetapi jangan gembira, ya. Jangan gembira merasa sudah divaksin lalu protokol kesehatan tidak dijalankan karena ini vaksin baru, kita tidak tahu proteksi. Ya, dan ada kemungkinan bahwa satu orang terproteksi, orang lainnya tidak, karena kita vaksin di atas 50%, ya belum tentu 100%. Ya, jadi walaupun sudah divaksin, Anda atau kita semua tetap menjalankan protokol kesehatan, ya, pakai masker, cuci tangan, jaga jarak. Tapi yang jelas yang menggembirakan bahwa kemungkinan untuk terinfeksi virus berkurang, tapi bukan nol sama sekali, ya. Mohon diingat itu, jangan kayak ada saya dapat video orang setelah divaksin lalu gembira-gembira buka masker, peluk-pelukan, ya itu nggak boleh ya.
Terus pertanyaan berikutnya dok, yang tentang hidroquinone, ada pertanyaan di bawah.
Oke, apa itu?
Ya. Mengenai efektivitas hidroquinone
ya,
sebagai obat.
Ya, tadi saya udah jawab sebagiannya karena menanyakan tentang apakah setelah vaksin kita masih bisa bebas nggak pakai hazmat, kan tidak ya, tetap protokol kesehatan ya. Itu jadi pertanyaan sama. Dan tentang hidroksikloroquine. Hidroksikloroquine memang untuk Indonesia kita masih pakai karena kita melihat masih efektif dan juga safety, aman. Ya, sementara kan di luar beberapa negara sudah tidak dipakai karena katanya tidak aman. Tapi memang kalau kita baca artikelnya, mereka, kalau saya lihat dosis hidroksikloroquine sangat tinggi ya. Jadi perlu saya sampaikan, hidroksikloroquine ini adalah obat malaria. Orang Indonesia, terutama yang banyak ya, itu dari zaman dulu kan pakai hidroksikloroquine nggak masalah, nggak ada yang mati kan. Ya. Jadi sekarang hidroksikloroquine dipakai untuk COVID karena memang ada efek antivirusnya, mencegah replikasi virus. Jadi hingga saat ini kita masih pakai dan tidak ada bukti yang selama kita pemakaian di Indonesia bahwa itu tidak aman. Jadi sementara masih banyak penelitian yang berlangsung di Indonesia, yang bahkan juga Badan POM sedang melakukan penelitian melihat efektivitas dan safety dari hidroksikloroquine. Saat ini kan Badan POM masih mengeluarkan emergency use authorization, jadi pemberian obat karena emergency. Jadi masih belum ditarik itu letter emergency use authorization, jadi kita masih bisa pakai.
Iya.
Ya. Bagaimana nih protokol untuk baju hazmat agar dapat digunakan kembali? Jadi baju hazmat ini ada dua sekarang ya, ada yang sekali pakai, ada yang bisa dicuci, disterilkan, dan bisa dipakai ulang. Apakah masker N95 bisa disterilkan kembali? Ada. Ya, ada beberapa negara yang mensterilkannya dengan rice cooker. Ya. Ada juga di Belanda yang mensterilkannya pakai autoclave. Ya, tapi ya menurut saya kalau N95 masih tersedia, kita pakai sekali pakai aja. Ya. Kecuali pada kondisi nggak ada masker 95, cuma punya satu, yaitu tadi. Bisa punya 4 ya. Setelah pakai, jemur di udara terbuka yang kena sinar matahari selama 4 hari, itu virusnya mati. Hari kelima boleh pakai lagi ya. Atau yaitu tadi ada percobaan pakai rice cooker, disterilkan, ada yang memakai tapi jangan bergantian ya, masak nasi terus steril N95, terus masak nasi lagi jangan. Kalau bisa rice cookernya khusus untuk sterilisasi N95 atau minta tolong rumah sakit untuk disterilkan dengan autoclave. Ya, demikian.
Masa pakainya dok untuk yang N95 ada nggak, maksudnya nanti kalau misalkan sudah ada perubahan bentuk atau mungkin sudah bagaimana sudah tidak bisa lagi terpakai?
Ya, jadi idealnya N95 itu sekali pakai dan biasa dipakai 3-4 jam ya. Karena 3-4 jam itu adalah kemampuan kita memakainya dalam ruangan isolasi. Jadi setelah itu biasanya sangat-sangat pengap ya dan berair, keringat di mana-mana sehingga harus diganti. Ya. Ada Prof Mansur atau Prof Mansur aja menyediakan N95 banyak untuk UNHAS ya.
Iya. Gimana dok kira-kira dengan waktunya? Masih ada kesempatan untuk menjawab?
Sepertinya pertanyaan sudah habis ya?
Masih ada di fasilitas.
It's not for me ya. Seperti
ada satu pertanyaan dok terakhir mungkin di fasilitas Q&A.
Oke, bentar saya tanya nih, bagaimana protokol penanganan infeksi berat dengan abses setelah konfirmasi positif ya, dan yang kedua bagaimana terapi antibiotiknya? Apakah dikombinasi dengan azitromisin? Ya kalau memang ada COVID dan ada abses juga, yang abses tentu saja biasanya karena kuman ya, bakteri bukan karena virus, maka ini obatnya harus juga azitromisinnya kan untuk COVID-nya, maka untuk absesnya harus diberikan antibiotik yang sesuai. Nah, jadi memang harus ada tambahan antibiotik untuk absesnya. Ya, karena azitromisin untuk COVID diberikan bukan sebagai antibiotik, lebih ke arah untuk antiinflamasi dan imunomodulator, tapi bukan untuk antibiotik. Jadi kalau ada abses, berilah antibiotik untuk absesnya sebagai tambahan.
Untuk manajemen ini dok, untuk manajemen ruangan, di sini ada pertanyaan terakhir mungkin yang terkait dengan pengaturan sirkulasi ruangan di tempat tindakan. Nah, misalkan mengubah tekanan ruangan dari tekanan positif menjadi negatif, itu kira-kira apakah berpengaruh terhadap untuk mencegah penyebaran dari droplet atau yang bisa menularkan COVID-nya?
Jadi pencegahan penularan itu kan ada 3 ya, ada administratif, ada environmental, termasuk engineering ya, dan satu lagi adalah personal protection. Yang kita lakukan banyak adalah protection, seperti pakai masker, pakai face shield, pakai Google, pakai gown, itu personal protection. Tapi ada lagi istilahnya environmental protection dengan membuat layout ruangan. Jadi dan juga ada engineering protection. Engineering protection itu yaitu tadi mengubah tekanan itu. Jadi kan biasa kalau untuk COVID kan diharapkan untuk yang berat biasanya tekanan negatif ya. Apalagi kalau memang itu terjadi aerosol di situ ya. Jadi sebaiknya memang tekanan negatif. Tapi bila mana itu akan mengubah struktur ruangan dan juga teknologinya agak susah, mungkin bisa disiasati dengan itu tadi, protokol kesehatan.
Yeah.
Membersihkan dengan desinfektan. Jadi kalaupun ada aerosol, tapi kalau dokternya pakai N95, pakai face shield, ya apalagi ada yang juga pakai Google segala macam, insya Allah sih aman ya.
Baik, terima kasih banyak dok
Ya.
Satu pertanyaan lagi dok, mungkin pertanyaan awam aja dok.
Ya.
Ini tadi memperlihatkan grafik dari COVID yang masih menanjak dok.
Iya,
nah,
itu karena masyarakat
kira-kira
nggak disiplin, karena kan penularan itu terjadi karena interaksi orang kan. Nah kalau interaksi orang ini tidak dikendalikan, jadi tidak ada jaga jarak, tidak pakai masker, tidak cuci tangan, ya kita akan naik terus. Padahal kan kita inginnya lepas dari pandemi. Untuk lepas dari pandemi nggak bisa ngandelin pemerintah aja, harus ada juga peran aktif dari masyarakat. Ya, pemerintah saya kira udah pusing 7 keliling nih.
Ya, sekarang tinggal kesadaran masyarakat aja dok ya. Iya.
Oke ya.
Iya, baik dok. Terima kasih banyak.
Yang di Q&A.
Iya, baik. Dr. Erlina, terima kasih banyak atas waktunya dok. Kami sangat mengerti bahwa Dr. Erlina kesibukannya sangat luar biasa. Kami dari Fakultas Kedokteran Gigi atau panitia memberikan apresiasi yang sebesar-besarnya kepada dokter yang sudah meluangkan waktunya untuk memberikan share pencerahan terkait dengan COVID. Ya, mungkin berikutnya akan ada pemberian sertifikat, dok. Kami akan tampilkan sertifikat sebagai apresiasi besar dari kami. Silakan IT hostnya. Iya. Iya, speakernya masih mute, dok.
Terima kasih. Ini saya lihat sertifikatnya bagus banget, keren ya.
Iya, mungkin dari Bapak Dekan.
Ya.
Terima kasih banyak,
Bapak Dekan, ya.
Dr. Erlina Burhan.
Iya dok, makasih dok.
Saya
merasa terhormat nih diundang.
Kami justru sangat berterima kasih. Saya mau sampaikan bahwa ICOBTD serasa ILC. Suaranya Dr. Erlina Burhan itu khas sekali tuh. Kami kalau dari dengar jalan, oh ini Dr. Erlina yang lagi bicara ini. Terima kasih banyak. Terima kasih banyak dokter. Terima kasih banyak.
Sama-sama dok. Boleh pamit ya?
Iya, makasih banyak.
Ya, silakan dok. Terima kasih banyak. Assalamualaikum warahmatullahi
wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ya, selanjutnya saya persilakan kepada Dr. Yosi untuk mengambil alih acara. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak, Dok. Baik, demikianlah akhir dari sesi 1 untuk kesempatan pagi hari ini. Ya, baik, kami informasikan bahwa dari tadi banyak yang menanyakan untuk absensi di form chat. Kami informasikan bahwa untuk webinar kita tidak akan ada form untuk absensi karena untuk absensi telah tercatat secara otomatis di link webinar kami apabila para peserta join pada Zoom link kita. Jadi tidak akan ada form untuk absensi karena sudah tercatat secara otomatis di link webinar kami. Dan untuk soal post-test, ya, sertifikat peserta akan didapatkan jika memenuhi nilai minimal 70% dari post-test, dan untuk soal post-test sudah dikirimkan linknya ke email masing-masing peserta, dan untuk waktu menjawab post-test dipersilakan sampai pukul 23.00 waktu Indonesia bagian tengah pada malam hari nanti. Dan para peserta, ladies and gentlemen, distinguished participants, our next session, second session will be continue at 12:30. So for those who registered as a participant for our next session, we invite you to join us again at before 12:30. So we're going to start our meeting in a short time and on time. Jadi kami mengharapkan kepada para peserta yang terdaftar untuk mengikuti sesi kedua, kami persilakan untuk nanti dapat bergabung kembali sebelum pukul 12.30. Acara akan kita mulaikan tepat waktu pukul 12.30. Terima kasih banyak. Selamat siang. Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semua. Once again, welcome to all of participants the 4th International Conference on Biophysical Technology in Dentistry. And now we are going to start our second session for today. There will be a presentations about oral health during and after COVID-19 pandemic, public health issues and opportunities that will be delivered by Professor Dr. Tuti Ningseh Muhammad Dom from Malaysia. And also there's presentations about the management of orthodontic practice during pandemic COVID-19 that will be delivered by Dr. Gigi Ardiansyah as Pawinru, Sp.Ort consultant. And as the chairman for this session is Professor Dr. Gigi Mansur Nasir, Ph.D. A brief introductions about our chairman for today. Professor Dr. Gigi Mansur Nasir, Ph.D., born in Wotu, Isluwu, in June 1954, graduated as a dentist from Faculty of Dentistry, Hasanuddin University, a research student from Department of Orthodontic, Faculty of Dentistry, School of Dentistry, Hiroshima University, and PhD awarded from Department of Orthodontic, Faculty of Dentistry, School of Dentistry, Hiroshima University. Professor Mansur Nasir, please, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera buat kita sekalian. Thank you, Yossi, for your it's very talented guide to guide us today. I really appreciate it for that. Can you hear me? Can you hear me?
Yes.
Okay, good. Dear ladies and gentlemen, first of all, I would like to say thank you very much to especially to Honorable Dean of Faculty of Dentistry, in this case, Dr. Kuslin, for his excellent program, especially for making the 4th ICO BTC, it made it happen today. Thank you also to the organizing committee for arranging and manage this occasion. And it is very important international scientific meeting virtually. Thank you to the whole distinguished guest, distinguished speaker from many countries, such as Japan, Taiwan, Malaysia, and also from Indonesia as well. Good evening, Professor Dr. Tuti Ningseh Muhammad from Malaysia, and I must the moderator will guide you to you for your presentation with the topic oral health during and after COVID-19 pandemic, public health issues and opportunity. Please, you could start your presentation. Its time is yours. Please.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
I hope I'm clear, and it's my slide clear?
Yes, very clear, very clear.
Okay, very good. Alhamdulillah. First of all, I would like to congratulate the organizers for a very well-planned virtual conference. Despite the odds, you've managed to come up with, I think, something that is very useful, very relevant, and managed to get so many collaborations. Tahniah saya ucapkan. Saya juga ingin mengucapkan terima kasih. Thank you very much for the kind invitation and for giving me this opportunity. Saya daripada Universiti Kebangsaan Malaysia, UKM, also known as the National University of Malaysia. We are happy if you are able to, from this opportunity, we can come up with some research collaboration, staff exchange. UKM is one of the 6 research universities in Malaysia. So the topic that has been chosen for me today is more of looking at the perspective of the population oral health. We have listened to the impact of the pandemic on dental education and also on how it has impacted services, dental services or dental practice. So today I would like to perhaps give some perspectives on what is the impact on the public oral health, and although there are issues that have come up, like anything we face, there are always opportunities. Yeah, there's always something good that we hope that can come up from this experience with COVID. So this is how I have organized my thoughts. It may come up that way, or sometimes when we speak, some ideas come in and probably we get other ideas. Also, hopefully, if there are questions at the end of it, we will get some other perspective and insights from all the participants of this conference, inshallah. So I put here the current global situation of the pandemic. At the end of July, which was last month, we actually reached the 6th month after the World Health Organization declared COVID-19 as a public health emergency of international concerns. We have passed the 6-month mark. In fact, today we are at about 7 months since then. At the 6-month milestone, there were about 16 million cases reported to the WHO. But today, we can see that it has actually increased to about 24 million confirmed cases that have been reported. We can see also that there are about 800,000 deaths that have been caused by COVID. And it seems that the pandemic has not cleared on a global outlook, and it appears to be still continuing even as we speak. And all this while, we have learned a lot about COVID-19, and there's still a lot more that we are learning. Sorry about the traffic. I am in Kuala Lumpur, so the traffic is just there. So at the end of the day, basic public health measures that we know and what we have been putting into practice, like the 3 T's, yeah, tracing, testing, and treating. We see that this has been able to save lives. And other also preventive measures that I think all of us are adapting as the new normal like keeping our social distances, practicing hand washing, avoiding crowded places, and if we can't, we are asked to wear masks. We know that these are some of the things that work. And in places where people actually follow these recommendations, we see that the numbers would be low, or they would come down. But in the places that people do not follow these guidelines, we see that the numbers are on the rise and keep rising. I'd like to share a little bit on the Malaysian experience on COVID. In Malaysia, the virus reached us in about January, late January, and at that time, the cases in Malaysia were relatively low, and they were just confined to imported cases, and it was not high at all. And after about March, the numbers seem to be rising to about 30 cases, and localized clusters started to appear. And by end of March, we were seeing actually about 2,000 positive cases in Malaysia. But the government of Malaysia had enforced a movement control order starting on March 18 to break this change of COVID-19. We learned that when we were facing this critical situation, we could count on each other to actually come together and support what we were trying to do for our country. We had organizations that hosted fundraising events to provide essentials to hospitals and our frontliners. The government set up extra hospitals. There were collaborations between the private sector and public sector. So these were some of the good things about humans that we could see during this pandemic. And together with the movement control order, or the MCO, there was an expected economic downturn because we were asked to stay home, and a lot of services were not open except for the essential services. And some people were affected, especially the daily workers, when they were not able to go to work. So the government had actually provided some financing stimulus, or some assistance, to make sure that at least everybody were not too badly affected by the order to stay home. So we started with a few phases of our MCO. The first MCO, or rather phase 1, the government introduced efforts to contain the outbreak. And I think this is familiar for many countries which also practice this. Like government and private offices are closed, except for the essential services. Healthcare services are essential. Dental services are also considered as essential. So clinics were not asked to close, but rather we were accepting cases that were urgent and considered as emergency. And so all this continued. At the beginning, it was thought that it's going to be just 14 days. But as it turns out, the problem was bigger than that, and the MCO had to be continued. And we have gone through these phases from mid-March, and we continued with our conditional MCO for phase 2, and we moved on. Right now we are in phase 3, which we call the recovery MCO. Okay, this is kind of where we are right now in Malaysia, where we can see that the numbers of cases have gone down, and life is almost back to normal. But we know that there's no such thing as normal as the way it used to be. But the new normal, the face mask, the taking of temperature before we go anywhere, and we have these apps on our mobile called My Sejahtera, that the government will make sure that we would scan wherever we go. We need to scan into this My Sejahtera, yeah, so that this would enable contact tracing to be done. So we now have reached most days 0 death, and the new cases have gone down to actually single digit, and sometimes it goes up to about 20. But it seems that things are more under control, and our RMCO, yeah, this recovery MCO is expected to end next week on the 31st of August, and we'll see what the government plans to do after 31st of August. 31st of August is also our Hari Kemerdekaan. So are we going to get our Merdeka from COVID-19? We'll see about that, yeah. So in Malaysia, these decisions actually a lot of banyak pihak ya yang akan berbincang dan akan melihat situasinya bagaimana. The Ministry of Health, of course, plays an important role to advise, but we have a Malaysian National Security Council that actually is responsible for coming up with guidelines and legislation and enforcement where people who do not comply, I think beginning 1st of August, if I'm not mistaken, those who do not wear face masks in public places will have to pay a fine of 1,000 ringgit. Yeah, so that is human behavior. If when we are asked to change our behavior, and when it's difficult, we need the law to come in and to force us to change this behavior. And we now go into the topic of COVID-19 and dentistry before we go into what is the impact of COVID on public oral health. So we've talked about the transmission. I think the previous speaker had explained and described a lot about the transmission of the virus, specifically in dental clinic settings. It can occur not only via direct contact, indirect contact, but also one of the things that we are concerned about as dentists or as dental practitioners is through the droplets or the aerosols that are generated by the treatment that we do for the patient. So this can take place, the transmission can take place from patients to the dental healthcare workers and vice versa, and reciprocal between patients or dental healthcare workers. And it can apply to either symptomatic, pre-symptomatic, and even asymptomatic individual. And the previous speaker had actually deliberated in this aspect. Also during the time about March and onwards, yeah, March, April, May, and so on, we find a lot of guidelines for dental clinics from many countries, from many professional associations and governments, because everybody was concerned about this potential transmission that could take place in a dental clinic. And this is an illustration of a hierarchy of which infection control is actually effective and what is meant to be least effective. We, of course, pay a lot of attention to the PPE. Yeah? We have to make sure that when we are in contact with our patients, that we need to mask up and protect ourselves with PPE. But then there are also other aspects of the infection control that needs to be addressed. And apparently PPE is actually the least effective. So the most effective is elimination, such as physically remove the reservoir. Perhaps if we close our clinics, then the patients don't come in, and we are well protected. But then we can't do that because dental care is essential, yeah, especially when it is an emergency, when people are having pain. And I think many from here, the guidelines also talk about triaging, a triage, yeah? Having a triage where the patients who come to the clinic will have to be screened and to check whether it is urgent or not urgent. And there's also the more use, we see more and more people are actually using tele-dentistry or doing consultation online with the patient to find out what is about their problem, or giving them some counseling and solutions to the problem, so that not everybody will come to the clinic, and the clinic is going to be hard if we are going to do social distancing for the patients at the waiting area. So a lot of things, the guidelines have come up, and while it is very useful, it could sometimes be quite confusing for the practitioner, the private practitioner, especially when maybe they do not have support from a larger institution like the government. So they're not sure sometimes the interpretation of the guidelines. Although the guidelines are there, the interpretation of the guidelines are maybe not clear. Okay, so with regards to COVID-19 and dentistry, these are the areas that could be affected by the pandemic, and it has huge impact finally on what I like to say, oral health of the population. Yeah, oral health of the population is the main topic for today. With regards to dental services, we know that the new dentistry requires a lot of steps, a lot of adaptations. Yeah, patients now need to actually call ahead and make appointments because we do not want so many patients in the waiting area. It has impacted dentists and dental team, creating fear and anxiety of the unknown, of the known. Even some practices had need to are now, I mean, all dental clinics are seeing much fewer patients now, and for a private clinic, sometimes they are going to be impacted even more. We've listened about impact on dental education this morning from the professor from Hokkaido, and he also talked about how research is affected. Because there are many things that we need to observe, yeah, like social distancing and all the infection control. So it is changing dentistry in many ways. So which is why today we're going to talk a bit about how it affects the people that we serve, yeah, which is the public who receive dental care from us. talking about population or health during the pandemic and after the pandemic, I'd also like to touch a little bit about before the pandemic. Before all this started, dentistry has not always been dental visits and dental treatment not always been the most looked forward to activity. Utilization of dental care is not so high. Yeah, people still are not very fond of seeing the dentist unless they are really in pain, really discomfort that they must come and see the dentist. So even before the pandemic, oral diseases are still very prevalent. Dental caries, we know, is still #1 in prevalence and the highest disease that affect mankind. And even periodontitis or the severe kind of periodontitis is actually #6 in prevalence, according to the Global Burden of Disease Study in 2010. Yeah, in looking at over about 300 diseases, dental caries untreated is #1, and periodontitis of the severe kind is #6. So this gives us perspective that even before the pandemic, the oral health status of the population is not that great. And what happens during the pandemic, the services that we are recommended that we can provide is just the urgent and emergency treatment. So in cases where there is active treatment, for example, patients on active periodontal treatment, orthodontic treatment, they're not going to be considered as urgent. So they will not go, they're not supposed to go to the dentist. So this would impact the care that they were already getting. And after the pandemic, we anticipate that until the vaccine comes, we still have to practice the new norms in dentistry. So these are the things that are what the patient faces in making a decision whether I would want to go to the dental clinic or not. So in this slide, I would like to highlight some issues related to population oral health, but starting from the services itself, the services that we provide. So we, during the pandemic, and now that in Malaysia, we are reopening, as we said, we have reopened our dental services to cases are not so urgent. This would, I don't have the data right now. We are doing some studies, but we don't have the data yet. But it is possible that when routine treatment is being delayed, cases that are not urgent would then become urgent. Malaysia, and I think in some countries in the world as well, during the peak of the pandemic, dentists were redeployed to do other things. So although clinics may be open, dentists are actually doing things like testing, like COVID testing, and being part of the team that are the frontliners, yeah, and not really doing dental treatment. Again, this causes interruption of dental services. There are instances with regards to PPE that they are considered as inadequate. In Malaysia, at one point, there was concern about the adequacy of PPE. It was although the country or the Ministry of Health had prepared to face this peak, yeah, in the numbers of cases, but there was concern that maybe the PPE was not coming on time. So dentists actually gave their PPE to the medical frontliners during that time, because they were we consider them as a priority. So, but that situation somehow had been dealt with. A lot of people, the public, coming forward, the NGOs came forward to provide assistance in either giving the PPE or giving the money, as well as sewing the gown themselves. And as I said earlier, there were guidelines that were provided, and for Malaysia, it was about May, that I think it was sometime in May, that the Ministry of Health came out with a very comprehensive guideline. The issue was then a lot of things were not researched. We did not have the information. It was not easy to come up with something when there is no evidence to support a particular practice. So we will see, we look through the guidelines that have been provided by from around the world, we will see that many are not actually evidence-based, but that was the best that people could do in a situation that we had not faced a pandemic this huge before, with severe outcomes to health and lives of mankind. And the SOPs that had the protocols that had to be developed require dentists and dental team to be trained and to be educated. In universities, our dental clinics setup are not the same as those in the government practice or in the private practice. And we have open, we have cubicles of dental students clinics. So that need to be aligned with the guidelines. So the impact on the services, in other words, have interrupted the way we used to practice and the way we organize our patients and our equipment and all the infection control. So dental services had been affected greatly because of this. And the impact on the public is the public had reduced access to dental clinics. And at the same time, there was also the fear factor. They would hear that the risk of transmission in the dental clinic during dental treatment would be high, and that caused them to be afraid of being infected if they were to go to the dental clinic. And for the typical public person, even before the pandemic, people would sometimes define, they don't really know whether it's a dental emergency or not. They're not sure whether if they have this pain on their tooth, and if it goes away, is that an emergency? If that pain annoys you and keeps you up at night, is that a dental emergency? If you take paracetamol and the pain goes away, is that dental emergency? So it is something that they need to define themselves, and this sort of information was not coming through very fast, yeah, because people had other concerns as well. And with the pandemic and with lockdown in some places where people cannot go out of their homes for months, people who lose jobs or lose loved ones because of COVID, they would be in a stressful situation. And sometimes people cope by doing things that are not healthy for their health and our health. They may start smoking, they may start snacking and taking more of unhealthy food that could have detrimental effect to their oral health and health in general. Some people may tend to neglect oral care in cases where people associate, going to work, getting dressed up, taking a bath and shower, brushing their teeth, staying at home, not having to go out. Sometimes people neglect personal care, personal hygiene, oral care included. And also the other thing that could happen, that could impact the public, is when they try to self-treat themselves and using home remedies for the dental problems that they have. There was a study looking at what people search, the kind of information that people search for in the internet. In past years, people would be searching for dental clinic near me, okay, or they would be searching for what are the opening hours of dental clinic. But during the pandemic, this study found that people were searching more for home remedies, and we know that some home remedies are may not be effective, and some home remedies could even be bad for the people's health and our health. So these are the situations that would arise in relation to the COVID and the impact on the population or health. There are also studies that found higher attendances for dental emergencies, and it is late emergency or delayed emergencies, like big abscesses, and there were cases of Ludwig angina, which are now supposed to be rare, yeah, but because of the delayed attendance to the dental clinic, it has impacted people in that way. So even when dental practices are closed, when dental practices are interrupted, oral health problems will still arise, and we know that. Yeah, I think we've all perhaps have members of our family or friends who have had to deal with dental problems during the pandemic. And without access to preventive or palliative dental care, the pain caused by problems like abscesses or periodontal infections may become more prevalent because of interruptions to routine dental care. Situations that are usually not a problem, like teeth that have simple fillings, may deteriorate during this time, and with the delay, it could be worse. The cavity could be larger and requiring more costly treatment when dental practice starts to reopen. Also, we see in the literature that there have been reports on how the problem with access have impacted vulnerable populations, people who also people who cannot afford dental care, people with special needs that require ongoing dental care have been more severely affected, and this cause again it makes the problem of inequalities of oral health even more amplified. It becomes more problem. More people are having to face these problems, and the problems have become bigger. So like I started just now by saying that like anything that is that anything that is problematic or worrying or bad, that have negative impacts, we'd like to look at whether there are good things that can come out of it. Yeah, whether there are opportunities that we can use, having gone through months of this kind of situation. So these are some of the opportunities that I can think of with the experience that we have had, and the data and studies that people are currently doing. We would now be in a better position to be prepared and have a contingency plan for modifying clinical practice and dentistry in the future. If we were to face this situation again, it would be that we're going to be better and more prepared compared to how we were when this pandemic started. So that is an opportunity to look at what we currently have in the clinics and start to modify. It's also time for us to look at our infection and cross-infection control protocols and see how we could optimize what we have, and the standard precautions. We need to look back at our universal standard precaution for cross-infection and see whether is that enough, or what else do we need to adjust or to adapt to optimize the protocols in different situations. Would we want to have different levels of protocols to address different phases of the pandemic? That is something that we can take advantage of from this situation. Perhaps we could take this situation as an opportunity to talk to patients and give them more empowerment to take care of their own health and oral health. Many a time in situations like this where preventive measures are available, there is a tendency for people not to undertake these practices. And this has got to be with people lacking or thinking that they are not susceptible to a particular disease, and therefore they do not need to take the action. Sometimes people think that, okay, even if I am susceptible to something, I'm not going to die because of it. It's not going to impact my life. But here comes COVID, and COVID tells us that if you could do something to prevent from getting infected, would you do it? So people would take this, would find and would realize that a lot of the success in managing the COVID-19 pandemic has actually come from the patient or the people's empowerment and them being more educated to improve their literacy in public health and prevention. And for dentists, it could be an opportunity for us to again look at our patient care and focus more on primary prevention. Yeah, and for those who require treatment, we could try and learn more about non-aerosol generating procedures. We could advocate for materials or types of treatment that are not so high in aerosol generating or do not generate aerosol. This is an opportunity to perhaps work with from the industry who are also keen to promote preventive treatment and also treatment that are what we would have wanted, minimal intervention. Yeah, minimal intervention is something that we have always promoted in dentistry to promote care for the patient. But in this situation, perhaps it becomes a priority, it becomes a choice, a preferred choice, yeah, rather than something that is considered as a second choice. We also see that with this pandemic and with reduced access to dental care, we are seeing that there is more people who conduct consultancy, teleconsultancy or teledentistry with the patient, yeah, to give them some advice and also to communicate with the patient. It could be also part of triage, where before the patient could come to the clinic, they could get online and look at see the dentist or a hygienist or a dental educator who can gauge what the patient needs in terms of dental treatment. And with that linkage through the online platform, patients will increase in their trust in the dentist, and we can take the opportunity to speak to them more about preventive behavior, oral hygiene care, even to quit smoking or to have a better diet. Okay, and dentistry, dental or oral health. Yeah, we know that oral health is an integral part of general health. You can't have health if you don't have oral health. Yeah, we know that it is something that is important. But in many ways, when people are considering looking at policy and prioritizing research, sometimes oral health becomes deprioritized. This is another opportunity that we could take, which is to actually work with the other players in healthcare to make sure that oral health is included in whatever situation or in whatever policy that people are making. Oral health should not be deprioritized. In fact, it should be included. Yeah, even when doctors are advising their patients on self-care, oral health should also be somewhere in the care pathway. So these are some of the opportunities that I could think of that I have shared with you. And in this slide, there's a little bit on opportunities that we could take when we are looking at the design of dental education as well as postgraduate training. Yeah, with this situation, we could ask ourselves whether our current curriculum could has included the role of the dentist in times like a pandemic. So if there are areas that we could improve on, we could consider to increase the emphasis on learning and practical training related to topics that could help enlarge understanding of infectious diseases. Apparently not just non-communicable diseases, now infectious diseases are giving us a new meaning on clinical practice, and it's important that our trainees or our students have a better understanding of this. Teledentistry is something that could be explored in the training of dental students and specialist training. Is there room for teledentistry, and what kind of skills do we need to incorporate? And not just the training or the knowledge, we need to also look at the designs, yeah, of dental clinics, dental teaching hospitals. We need to be ready next time. We hope there is no next time, but then who knows what is going to come in the future, and we need to be ready with the evidence for safe dentistry and safe dental practice. And with regards to interprofessional learning experiences, we need to provide more of that for our students, because in situations like this, we see dentists working with doctors, working with frontliners to help in the testing and in the managing of the patients with COVID-19. So some of the design that we could consider would be design of the clinics, would be foolproof, capable in preventing transmission of airborne, bloodborne, contact-borne viral and bacterial infections. These are, when I say it's opportunities, sometimes if we don't have this kind of situation, sometimes we are not thinking how we could improve. But situations such as this COVID-19 pandemic has forced us to actually think of doing things better and having plans for the future in to manage our students and our clinical practice. So there is no level that will save us from corona, because the problem is not the level set by government, but is people mentality and behavior. So while we have dental services that are provided by us, we are people too. And the people that we serve, which is the population, will need to have a mindset on what oral health means to them and what they are willing to do to make sure that oral disease could be prevented by their own actions. Yeah, because having gone through interrupted dental services, lower access to care, I think some of the people wish that they had better dental status. Yeah, they had better teeth, they had better mouth, so that they don't have to be in pain when they can't get to the dentist. So from that perspective, it is always again back to the behavior of the people, which is affected by the mindset of the people. So with that, I thank you for listening, and I end my presentation here. Thank you very much.
Thank you very much to Professor Dr. Tuti Ningseh Muhammad to Malaysia. We really appreciate it very much for the really excellent lecture for us, and we learned a lot about your experience in Malaysia. I believe that you are ahead of us because of the how do you say, the you can reduce the number from let's say from 9,175 cases, and today you are going to have about almost zero. Yeah, almost zero. It's mean that it's really good to learn, good lesson to learn from you, and Alhamdulillah, that's is kind of some kind of gift from Allah Subhanahu wa Taala for your merdeka from COVID-19, especially in August 2020. And we understand that a lot of things we learned today. So especially the how could you manage, manage especially in education. So we have, let's see what I got here. That let me see. It's about this is very important for us about the dental education and postgraduate training. It's about infectious disease, dentistry, and how do we design the new dental clinic and dental teaching hospital, and interpersonal learning experience. Yeah, important for us. But you mentioned about the philosopher of DJ Chaos saying that mentally and behavior. This is a very, very much, we have to take care of this statement that mentally and behavior. So we really learn a lot from you, and for all audience, we would like you to write something. Maybe you need to ask about anything about Professor presentation that really excellent, and but you can pakai bahasa Malaysia or bahasa Indonesia, tak apa.
Ya, insyaAllah.
Sekarang boleh pakai bahasa Malaysia atau bertanya, nanti dijawab dalam bahasa Malaysia boleh, tapi lecture tadi dalam bahasa Inggris is okay. Ya. So I think everybody understand that your lecture is very good, slowly, but we can understand perfectly. So audience, please write something that maybe you can ask, and Professor Tuti will explain to you deeply. Please, if you have any questions.
I see one question at the question and answer.
Yes, please.
From Dr. Fuad. I think he was responsible to invite me, Dr. Fuad. How dentists provide services to patients in dental clinics during COVID-19 in Malaysia? They need special additional tools or facilities. Okay, saya cuba jawab ya.
Boleh jawab bahasa Malaysia boleh supaya kita mengerti.
Ya. Jadi I mix ya. In Malaysia we like to mix the bahasa Malaysia and bahasa Inggeris. So during the pandemic, our Kementerian Kesihatan Malaysia, our Ministry of Health, came out with some guidelines on how the dentists can provide dental treatment during the pandemic. Jadinya apa yang diperlukan would be the PPE, right? Dan tetapi selain daripada itu, amalannya ialah untuk ada screening semasa patient datang ke klinik. So screening tu kita mendapatkan maklumat sama ada mereka demam ataupun pernah ada kontak dengan orang yang positif COVID. Pada awal kita punya MCO itu, inilah yang kita amalkan. We open only for emergency. So sekiranya pesakit itu datang dan dia bukan emergency, then the patient will have to be turned away. Yeah, that was permulaan MCO. I wouldn't say that we had really additional tools or facilities, but efforts were taken untuk pastikan sanitization, kebersihan. Sebenarnya dentist memang bersih ya. We are among clinicians yang sentiasa sangat alert dengan infection control. So sebetulnya pada saya, kita sebenarnya tidak perlu membuat begitu banyak adjustment. But because we are in a pandemic, we need to know the patient's history. Yang paling penting ialah the patient's history. And also yang saya telah mention tadi ialah sekarang kita dah reopen dental services, jadi pesakit untuk semua klinik kerajaan perlu call in untuk mendapatkan appointment. They cannot walk in, you know, unless they are emergency. Then again they have to go through the health screening semasa di klinik. Saya harap itu dapat membantu menjawab soalan Dr. Fuad.
I myself would like to just say that you are lucky. Your government already, sponsor money. In this case,
Yes.
fund. Yeah,
Yes.
it's about. Let me see. First is about 20 billions, and the last one is 250 billions. That's quite a lot of money. So
Yes.
it's mean that you also from university you got some kind of benefit from them. And the second, I just want to know. We just want to know about what do you think about the second wave of this coronavirus? Is there any information about the second wave in Malaysia? Gelombang kedua.
Gelombang, ya. We have been concerned because we had I can't remember exactly, but we had I think almost 1 month of not 1 month, about 1 month of single digit cases. It's hard we haven't really got zero, but you know, maybe 5-7 cases. And then I think dalam 2 minggu atau 3 minggu yang lalu we have like 14 and then going up to 28, and we are concerned again. But to say whether it is actually a second wave or a third wave, is it a new wave or is it saki-baki daripada wave yang sebelum ini yang belum selesai, yeah. But the recent case yang ramai itu, I think it was from it was imported, it came in, and perhaps people melanggar perintah, you know, melanggar perintah when you're supposed to be in isolation, quarantine, you don't quarantine yourself. So itu yang menyebabkan kerajaan mengambil tindakan keras apabila ada kes-kes yang langgar quarantine. Because these are, when we follow the instructions, we can see the numbers going down. But then when it goes up, it's because of some new thing that is happening. Otherwise, we have ada 14 negeri di Malaysia, and kita semua sudah green, going green, and then suddenly ada merah, red zone, yellow zone. But I think in the last we get our daily reports. I think that yesterday we have 5 green zones, no new cases. Green zone mean no new case in 14 days. So the bottom line is, I think, what di Malaysia, yes, alhamdulillah, and I sangat-sangat bersyukur that our government is able to provide, memberikan sokongan. Kita duduk di rumah macam saya, we started going back to the university, I think in, was it June or July, I can't remember already. But we work from home for a few months dengan gaji penuh. I mean, syukur sangat ya, tak ramai orang yang dapat macam tu. So kerajaan will really take care of us in that way. That's why we were able to manage the pandemic in a good way. Yes. But I was going to say that the university, our clinics were closed for a long time because arahannya ialah university perlu tutup. So we opened up again sometime in July. Again, sesuatu yang juga saya rasa sangat bertuah di bumi Malaysia is also the generosity of rakyat Malaysia sendiri. Whether you are from NGOs, NGO perubatan, NGO pergigian. Saya pun I'm a president of my Dental Public Health Association. Kita ada rakyat-rakyat biasa yang sangat mudah dan suka menyumbang. So the faculty pergigian UKM, we have a lot of derma untuk PPE dan lain-lain lagi keperluan untuk membasmi kuman dan sebagainya. So we are still fighting though. We are hoping that it will be under control soon, and we doa for you as well in Indonesia that we will be able to solve this problem.
Okay, mungkin ini my last question. Ini bukan question, kira-kira planningnya. What do you plan for the student in the for the how do you say the clinical requirement? So it's mean they have to do it clinically for the or something else you do clinical. That's my last question.
Okay, thank you, Prof. Mansur. It is still it's a bit I would say agak premature untuk saya menyatakan kita ada perancangan yang mantap. Kita belum ada perancangan yang mantap, dan we have at the moment that we are facing, kita ada 13 dental schools here di Malaysia, and there are many that ada yang sudah selesai final exam dan ada yang belum lagi, dan kerajaan Malaysia allowed only the final year students to come back into the campus untuk menyiapkan requirement for graduation. Sama ada dia dental, medical, or apa-apa student juga dibenarkan pulang hanya final year saja. Yeah, so whereas yang lain tu akan pulang ke campus secara berperingkat, probably in October when our semester opens. So untuk yang tahun 5 ini, we had to make some adjustments to our requirement. We want them to graduate. So if for patients that can still come to the clinic, they would be the patients will come to the clinic for treatment. Yeah, but we try to minimize hanya kes-kes yang perlu saja, and the students also have a responsibility to the patients to complete the treatment. So itu kita lakukan, tapi pada masa yang sama juga ada requirement yang dilakukan secara simulation sahaja, which is going back to the operative lab ataupun simulation lab untuk mereka complete the case. Yeah.
Terima kasih banyak Profesor Tuti, because our time is already very limited, so kita mengucapkan tepuk tangan dulu ya buat Profesor Wal.
Terima kasih.
Really very excellent. So now I give the time to Yosi, please. Yosi, stand. Yosi, our organizing committee. Yos. Dr. Yosi. Dr. Yossi or anybody else that ini Pak Dekan mau berikan sertifikat. Tapi Yossi mana Yossi? Yossi?
So while waiting the moderator,
yeah, please. Dean,
I would like to say deeply honor to Professor Ningseh for your time to share your knowledge in this event. Again, thank you very much, Professor Tuti Ningseh.
Thank you very much, Professor.
Yeah, it's nice.
It has been a pleasure, and I hope I've been able to share something useful.
Yeah, thank you. And we hope next time you can come if already pandemic already gone.
I'm very happy to.
Yeah. And now we would like to share your certificate, please. This is your certificate. We will send you by email. And again, Professor, thank you very much. Terima kasih banyak.
My pleasure. Sama-sama.
Next time, datang ke Makassar.
Insyaallah.
Ya.
Oke. Saya pergi dulu ya.
Ya, makasih banyak.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak, Prof. Mansur.
Ya, saya masih lanjut kayaknya.
Ya, ya.
Mana?
Lalu berprolasi.
Assalamualaikum warahmatullahi wabarakatuh. Can we start? Halo, Yossi.
Siap,
Yossi.
Prof. Siap, Prof. Baik.
Sudah bisa start atau dipersilahkan dulu?
Boleh langsung, Prof.
Ya?
Boleh langsung.
Langsung. Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama kita mengucapkan terima kasih kepada seluruh audiens yang telah mengikuti sesi pertama. Selanjutnya kita akan lanjut ke sesi kedua, yaitu Management of Orthodontic Practice during Pandemic COVID-19, a Literature Study, yang akan dibawakan oleh Dr. Ardiansyah Pawinru, Sp.Ort konsultan dari Departemen Orthodontic Hasanuddin University. Mungkin minta tolong ke Yossi, mungkin minta tolong dibacakan kurikulum vitae-nya dulu. Okay. Halo, Yos, Dr. Yossi.
Ya, siap, Prof.
Ya. Kurikulum vitae. Halo?
Ya, Prof.
Kurikulum vitae Dr. Ardiansyah, minta tolong dibacakan kalau.
Baik, siap. Baik, apakah suara saya terdengar?
Ya, terdengar, yes. Terdengar.
Baik, mohon izin untuk menyampaikan kurikulum vitae untuk materi kedua. Okay, ladies and gentlemen, I'm going to read in English. There's a brief curriculum vitae of our second speaker for the second session, Dr. Gigi Ardiansyah S. Pawinru, Sp.Ort, consultant, born in Maros, August 1979, graduated from Dentistry Faculty Hasan University as a dentist. In 2005, graduated as an orthodontic specialist from Pajajaran University. In 2014, he is now as the lecturer staff of orthodontic department in Faculty of Dentistry Hasan University.
Enough? Yosi?
Yes, enough, Prof.
Okay. Dear ladies and gentlemen, all the audience, we come to the second section, the presentation of Dr. Ardiansyah. So, management of orthodontics, once again, management of orthodontic practice during pandemic COVID-19, literature study. Dr. Ardiansyah, time is yours, please.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Do you hear me? Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good afternoon, everybody. Alhamdulillah Rabbil Alamin, and thanks to Prof. Mansur, moderator, and greetings for Prof. Tuti, Ningseh. Nice to know you. Today, I would like to explain more about a little about orthodontic practice, how to manage, and my title of presentation is Management of Orthodontic Practice during Pandemic COVID-19. Yes. Firstly, we know COVID-19 first reported in Wuhan, China, on December 2019, and after it, WHO announced about COVID-19 as a pandemic in March 2020 because COVID have in more 200 countries have a problem COVID-19. So the big problem for pandemic is beside about health, the impact of COVID-19 is global economy. Many companies have to stop. Stopping employer jobless, and after it, the impact of problem of economy is social life, violence, divorce, theft, and many and the others. So the government have to think about a problem of economy. So we, including dentistry, we have to stop to practice to treat patient because the COVID. We know COVID-19 transmission with respiratory droplets and contact transmission and aerosol, and that is so very close. Very with our job as a dentist. Yeah, because dental care procedure as a dentist have arise of COVID-19 transmission. So like PDGI, professional organization in Indonesia, Indonesian Dental Association, make some regulation, a number of main reference relating to health service issues during COVID-19 pandemic. The point of reference, the main point is for a clinic or dental hospital is a good management, including managing orthodontic patient, especially during a pandemic. Yeah, this is a recommended step in patient management. Generally, for orthodontic or dentist or general patient is have a similarity procedure protocol COVID. First step is provide patient with a broadcast communication. So you have we need to often send broadcast SMS and ORA communication to the patient, and then assessment of patient risk level, and then again provide information on home treatment progression, and use teledentistry facility if for the minimal problem in on a patient, and provide emergent orthodontic treatment in a safe manner if necessary, and provide training to all staff in orthodontic clinic on emergency cases during pandemic. Yeah. What kind of emergency case in orthodontic? Yes. First, we have many dentists or specialists usually ask me about the emergency case in orthodontic. Yeah, I would like to explain a little about emergency case. Is just the device when injures the gingiva that causing trauma, pain, mobile infection, or mobility teeth. Yeah, because mobility teeth, because usually we do false activation. Yeah, this is a step to strengthen the organizing and management system in dental practice. First, make systematic plans and procedure for the preventive and controlling COVID, and then second, provide training to all staff, including cleaning service and security maybe. Ensure that everyone understand every COVID-19 prevention and control. Then arrangement access to orthodontic clinics that are adjusted according to pandemic condition. Then personal placement in charge of patient regulation who will receive orthodontic service must be adjusted to the expertise, knowledge, and training that they have acquired. Fulfillment of preparation of adequate facility to support the implementation of their duties. Now, how to use of PPA properly? First, use mask, eye protection, gown, hair covers, full face shield, shoe covers, gloves, and hazardous material suit if in clinic available. For a well patient with non-aerosol procedure, we could use a surgical mask, but highly recommended to use filtering face fish respirator, like such as N195. But for a well or suspect or confirmed positive COVID-19 patient, aerosol or non-aerosol, we need disposable mask and 19.5 FFR or better with certified NEOSH, or better example R95 or P95. And again, providers should acknowledge that surgical masks do not provide the same level of protection as a tight-fitting N95 mask. Change mask between patient and during treatment if mask become wet. And then face shield should be thick, tight fitting. If reusable, you need disinfected and not have any sponge, pin, or pins attached. This is how to donning PPA properly. First step, you in a clinic or when we would like to treat patient, first step is washing hand hygiene, and after it, wear gown, and then wearing mask or respirator, and using goggles and face shield, and back to washing hand again, and use gloves, and after it you can go to a patient room. How about doffing PPA with properly? Yeah, after we treat patient, first step, remove gloves, remove gown, and then exit patient room, and then hand hygiene, washing hand, and after it remove face shield and goggles, and then remove mask and respirator, and then again washing hand hygiene. Yeah, for orthodontic, yes, orthodontists, yes, this is recommendation to reduce the risk of cross-contamination in orthodontic practice. First, orthodontic pliers can be sterilized with stem autoclave sterilization, ultrasound bath, thermal disinfection, or disinfected with chemical substance 2%, glutaraldehyde, or 0.25% paracetic acid. For orthodontic markers, you can use autoclave or disinfect it using glutaraldehyde solution. How about cleaning photographic retractor? You can use washer disinfector. Tungsten carbide debonding burrs could be effective decontaminate from bacterial infection, flushing dental unit water line for at least 2 min, or using disinfectant. The problem of patient of orthodontic with removable implants, because we need high cooperation with patient. We need usually to activate the appliance, wearing removable clear aligner, retainer, functional tools, and etc. That is, we have to often to meet this patient. So this is the require high cooperation with patient, and this is we have to explain more with the patient about protocol COVID and about protocol COVID. I will try to explain more about waiting room management in dental practice. Ideal waiting room for a private clinic or dental hospital for a dentist. First, equipped with toilets, hand hygiene, with non-absorbable and corrosive material, easy to clean. And then minimize corners so they don't collect dust and easy to clean. Installing barriers in the form of glass, plastic at the counter, customer service, and then air circulation is not closed. We need, this is describe a picture of waiting room management. Yes, we need fresh air grill, exhaust in the waiting room, and we put the chair with follow the protocol COVID, social distance procedure for patient. How about toilet management in practice? Yeah, we need ideal toilet installation. The toilet needs installation of exhaust in the ceiling with dilution capability and air intake from the air grill at the door, and refers to a closed type sputum booth, and then using cleaning by cleaning service staff or untying toilets require education and simulation to avoid droplets splashing on walls and floors, and then ensure the sanitary system to the final waste disposal installation. This is described or picture ideal toilet in the clinic. Yeah, how about practice room? Yes, first we need usually we need negative pressure. We need self-closing door for patient in exit direction of the interlock system, equipped with laminary airflow system with HEPA filter filtration, 97%. Usually we found in portable dental aerosol suction, and we need electricity from 3 sources: PLN, UPS, and Genset. Like it, we need in-house grill and ex-house grill. The last is instrument decontamination room management. Ideal instrument decontamination is first need ex-house outlet in the dirtiest area, and air is entering from the clean zone, and then one-way disinfection flow, dirty reception, and selection of floor material, wall pane non-absorbent, table not stained, and not angle avoid wood material. And then sanitation in discharge to final wash disposal installation, and periodically checks the quality of clean water. Like that, we need exhaust in button of crown. So the last conclusion, there are concerns related to the transmission of COVID-19 in the implementation of orthodontic treatment. It is deemed necessary to carry out good management in orthodontic practice. Planning, organizing, activity, and controlling are needed to regulate the workflow of orthodontic practice during the COVID-19 pandemic. Provide teledentistry facility and technology if available, as well as adequate facility and infrastructure in accordance with the standard of professional organization and related government. Thank you so much, Prof. Mansur. Please, thanks.
Thank you very much to Dr. Ardiansyah. It's really excellent presentation, and therefore we would like to say thank you and really good appreciations. We have learned many things from Dr. Ardiansyah, especially how to manage the orthodontic practice. So, because as we know that the COVID-19 is very dangerous, so we have to be careful. So we have to follow the instruction of the work Dr. Ardiansyah just told us. So the most important is about the management. So management, we have to be not only good, but the best management in orthodontic practice to avoid such transmission of COVID-19. In this case, he explained about planning, organizing, activating, controlling, and are needed to regulate the workflow of orthodontic practice during COVID-19 pandemic. So he also explained deeply about from patient enter a room, and then all kind of related to orthodontic practice, including their toilets. So it is very very good for us. So is there any questions? Audience could write down in chat or question and answer. So please.
Ada satu, Prof.
Yes, please. Yes, please.
Ya, saya langsung saja menjawab.
Yes.
May I with bahasa?
Well, you can English first, and then you can make it.
Ya, from Inna, saya kira untuk sekarang ini dengan apa namanya, tetap merawatnya dengan yang pertama yang saya sampaikan tadi, perlu asesmen yang jelas terhadap pasien. Jadi tidak datang dengan sendirinya, tapi diakses dulu pasien, apakah pernah keluar kota, apakah pernah ke sakit, atau pernah bersentuhan dengan positif COVID. Itu yang dilakukan di praktek, karena sekarang dengan new normal ya, yang diterapkan oleh pemerintah, maka semua bisa dilakukan dengan protokol COVID. Caranya di klinik adalah pasien itu harus dengan assessment yang ketat. Ya, kita yang tadi yang saya harus sampaikan bahwa kalau ingin kontrol, kita tanya dulu apakah pernah keluar kota. Ya, kalau pernah ke daerah red zone, misalnya dari from Jakarta, saya kira kita harus tunda dulu. Atau pernah bersentuhan dengan positif pasien positif terkonfirm, ya we need menunda ya, cancel. Kemudian atau pernah sakit dalam artian sakit yang merupakan gejala COVID. Nah, itu yang dilakukan untuk melakukan perawatan non emergensi. Jadi kalau untuk melakukan perawatan non emergensi, misalnya ada yang ingin kontrol biasa atau pasang braces, ya kita tanya dulu minimal itu. Atau ada juga klinik yang berlakukan rapid test, ya, tetapi saya kira agak repot kalau itu. Jadi itu tadi asesmen yang ketat, kemudian komunikasi by WA ya, dengan sebelumnya apa jadi yang keluhannya, sehingga meminimalisir perawatan apa namanya tatap muka atau bicara secara langsung dengan pasien. Yang ketiga ya tetap use PPA adequate ya, yang level 3 kalau tidak salah dengan APD lengkap, masker N95 minimal dan surgical mask, face shield, gown, gloves. Saya kira itu semua yang dilakukan dengan non elektif. Jadi intinya secara umum sama dengan praktek-praktek kedokteran gigi yang lainnya. Yang ketiga, yang non emergency yang kita pilih adalah yang kira-kiranya tidak non aerosol. Jadi misalnya kalau ada pasien yang lepas bracket, ya kita minimalkan pekerjaan aerosolnya. Jadi biasanya kan kita bur giginya, debonding ya dengan bur, nah itu kita hindari dulu karena di situ ada rawan terjadi transmission penularan. Saya kira itu untuk pertanyaan Inna Husnul Ibnu, Dokter Inna.
Cuma satu pertanyaan ya dokter, only one? Hanya satu ya?
Iya, di anunya hanya satu dok.
Oke, last time Dr. Ardiansyah explained that first, before doing the orthodontic treatment, we have to be very tight in the assessment first. And the second, minimalize the face-to-face. So it means that it is possible not the patient come to your practice. The third one is the PPE must be adequate. Yeah, at least level 3, and the last one is choose the non-aerosol, like there is the bracketing something. Don't use any boards or machine that produce aerosol. That's all he explained about the maybe that you may understand about that. And then, is there any question anymore? Hello? 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 Masih ada pertanyaan? Dr. Ardiansyah?
Sudah tidak ada, Prof.
Okay, so no question is mean that this session already done. We thank you very much to Dr. Ardiansyah.
Thank you so much.
Really give excellent presentation, and we really appreciate it very much for that. And now we Dr. Yossi it's yours now. Dr. Yossi is yours. Please.
Thank you very much, Professor. Thank you very much also some information for the post-test link will be sent to the email dikirimkan ke email masing-masing peserta. Jadi kami persilakan untuk dapat mengecek email masing-masing peserta. Kami berikan batas waktu untuk pengisian post-test hingga waktu Indonesia bagian tengah. Dan untuk daftar hadir, Bagi para peserta yang sudah join ke link Zoom webinar kita pada hari ini, itu akan otomatis tercatat dalam sistem kami hadir dalam webinar kali ini. Dan kami informasikan juga kami ada 42 peserta short lecture yang telah mengirimkan PowerPoint-nya dan telah membagikan presentasinya dan sudah diupload oleh panitia ke link YouTube kita di Dentistry Hasanuddin University. Jadi bagi para partisipan mungkin yang ingin melihat presentasi dari para short lecture kita, kami persilakan untuk dapat mengakses di YouTube channel kita Dentistry Hasanuddin University. Baik, sebelum kita melangkah ke sesi ketiga, ya kami informasikan bahwa sesi ketiga akan dimulai pukul 15.00 waktu Indonesia bagian tengah. Ya, oh ya, baik. Untuk sertifikat kami informasikan bagi para peserta, kami akan mengirimkan sertifikat bila oh ya, baik, siap. Mohon izin kepada speaker ya, siap. Mohon dan bagi para partisipan, para peserta, sertifikat akan kami serahkan apabila telah melulusi kosong waktu Indonesia bagian tengah dengan pemateri Prof. Yung-Kang dari Taiwan dan Profesor Dr. Gigi Boy Muhlis Bakhtiar MS Ph.D. Dengan chairman kita nanti adalah Profesor Dr. Gigi Asmawati Amin. Jadi kami informasikan kembali acara akan kita jeda sejenak hingga pukul 15.00 nanti. Terima kasih. Selamat siang. Speakers, Profesor Yung.
Tuan Dia. Halo.
Halo, Professor.
Hi.
Hello. And for the chairman to lead the session will be Professor Dr. Gigi Asmawati Amin. I will read a brief CV about our chairperson for today. Professor Dr. Gigi Asmawati Amin M.Kes, born in September 1968, graduated as a dentist from Faculty of Dentistry Hasanuddin University in 1994, graduated as a Master of Biomedic in Faculty of Medicine Hasanuddin University in 2003, graduated in Doctor of Clinical Specialty of Orthodontic in Hasanuddin University in 2011, and Sandwich Program in Brisbane University, Australia in 2011. Some of her research experiences in gene mutation as a risk factor for periodontitis, and also the descriptions of calcium, alkaline phosphate, and osteoblast value on bone graft calcium sulfate applied to bone defects. Professor Asmawati, please, the time is yours.
Thank you, Dr. Yamsi. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everybody.
Nice to meet you, Professor Yung-Kang. Good luck to all of you. Thank you very much to the presenter, special for Dean Hasanuddin University and committee for giving me time to guide the core activities of the presentation for International Conference on the Biophysical Technology in Dentistry. As the main theme of the session, we will hear together and gain knowledge with Professor Yung-Kang. He has been a professor of the School of Dental Technology in Taipei Medical University Hospital and Professor Dr. Gigi Boy Muhlis, Ph.D. Pakar Biologi Oral. He has been a professor of Biology Oral Department, Universitas Indonesia. We deserve to be grateful because we will immediately gain knowledge from the expert. Well, each speaker will be given 45 minutes to explain the topics, and question and answer for 15 minutes can be entered into the question field. And before the starting, I will read CV of the first speaker. Professor Yung-Kang received his PhD degree from the National Taiwan University, Taipei, Taiwan in 1995. He has been a professor of the School of Dental Technology of Taipei Medical University since 2014. He has been a chairman of the School of the Dental Technology of TMU since 2018. And he also of the director of Biomedical Nano Microforming Lab of TMU, the researcher of Nano Tissue Engineering and Image Research Center of Taipei Medical University Hospital. And Professor Sin also the chairman of Taiwan Oral Biomedical Engineering Association, the supervisor of SME Taipei chapter and director of Taiwan Society for Abrasive Technology. Professor Steen was awarded the Best Paper Award for the 3rd International Forum on System Mechatronics in Singapore 2010. He was also awarded the first prize in Poster Presentation Award for the 2nd Research Week International Symposium 2012 of COM on Dental Technology, Oral Healthcare, and Biomedical Device in Taipei in 2012. He was also awarded the Most Cited Article Award 2012 to 2013 for International Journal of Precision Engineering and Manufacturing. Professor Steen currently serves as the editorial board for Biology, Engineering, and Medicine, Journal of Precision Medicine and Public Health. And Professor Steen also currently serves as the special issue editorial for special issue application of the biocomposite material on bone reconstruction of applied sciences. Okay, let's start the presentation for Professor Yung-Kang. The time is yours. Please, Professor.
OK。哎，他好像没有我的，只看到没办法把我 PPT。再来一次。哎，这样可以哦。好，good afternoon, everyone. Can you hear my voice?
Yes.
Okay. Okay. Let us start our course now. I'm so happy to present my paper on here. Because COVID-19, we together cannot group together, but I think in the internet we can talk about our research on the full world. And the topic of my papers is 3-dimension PCL plus graphene hollow scaffold for bone repair. I'm Professor Yung-Kang. I'm the chairman of the School of Dental Technology, serve as the Taipei Medical University. Let me introduce Taipei Medical University firstly. In 2020, QS World University Ranking, Taipei TMU wins the 379. In 2020, THE World University Ranking, TMU get the 351. For 2020 QS Taiwan University Ranking, TMU wins the number 8. Finally, 2020 for THE Taiwan University Ranking, TMU gets the number 3. So I have the new information on now. In about 1 hour ago, we know the new 2021 QS World University Ranking, Taipei Medical University wins the 301. That is the good news for TMU. Sorry. This is the campus of TMU. This is our main campus for TMU. And you can see we have the high building and we have so many buildings in our campus. There are 4 hospitals in our university. The first is Taipei Medical University Hospital, located near the TMU. Wanfang Hospital in New Taipei, in Taipei City. Shuanghe Hospital in New Taipei City. Especially, we have the Ningbo Medical Center in main China, the Huili East Hospital in Ningbo. Now I will introduction my topic. So let me introduce the graphene, introduction to PCR scaffold. Finally, I will make a notification for this research. For history of the graphene, you can see in 2020, knowing about the graphene, in 1948, Ross and Mohd observed the image of the graphene under TEM. In 2004, Jim and Lomonosova produced the graphene by astrology method, used a very simple method, used the 3M tape. In 2010, Jim and Lomonosova wins the Nobel Prize in Physics. Nowadays, application for graphene uses so many fields. The first is material. The second is the electrical industry. The third is biomedicine. Let me introduce the graphene firstly. For the Jim, in 2009, they find a graphene firstly. You can see in the right side a flat molecular of carbon atoms. The graphene is the 2-dimension plate and the 2-dimension honeycomb letters. For the mechanical properties, graphene has the very maximum Young's modulus for 1 gigapascal. They have a good electron mobility for 15,000 cm square per voltage second, 10 times better than monocrystalline silicon. And they have the smallest resistivity for the 10⁻⁶ degree omega cm. They have a good thermal conductivity for the 5,300 watt per meter K, better than the carbon nanotube. For research in biomedicine field, for graphene, and the other is a graphene oxide, they have used so many fields. The first in tissue engineering, the second is gene and drug delivery, the third is nano bioelectronic device. So you can see graphene used so many fields in the biomedicine. This is the some research for the other peoples. For the M.Sc, muscular stem cell for day 1, day 3, day 7, day 10. For the pure PDMS and use the graphene, you can see on the day 10, the graphene has get a very good cell culture in here. And in the right side, you can see the graphene use the U87 and the U118 kilovolt cells. So you can see graphene can get a very good result in biomedical engineering. This is the other research for graphene. You can see graphene is the slider gray region for the cell culture. Graphene can get a good cell culture for the functionality. And for the bioavailability, the graphene also can get a very good result in here. Now let me talk about what is the tissue engineering. There are 3 topics for tissue engineering: cell, scaffold, and the growth factor. In this research, we emphasize the scaffold and finally use the scaffold to do the cell culture. Scaffold. There are so many limitations for a good scaffold. You must need a good scaffold is a non-textile and the biocompatibility, porous structure, and the good pore interconnectivity, and the suitable pore size and the biodegradability. There are so many materials can use on the scaffold. The first is natural material, like as the ginseng, zinc proteins. The second is a ceramic, like as beta TCP, HA, and so on. The third is the polymer, like as the PCL, PLA, and the PLGA. For the PCL scaffold, we must have a good, they have a good pure PCL. They have a good biocompatibility, long textile degradation products, easy processing, but they has some faults in their properties. That as the PCL scaffold has the hydrophobic, poor mechanical properties, acing degradation products. So we must to improve these points. So in this research, we use the PCL plus graphene to stop these problems. Let me talk about the micro nanostructure on the natural bone, because in this research, we emphasize on the bone cell for the scaffold. So let me introduce the bone structure on here. You can see this is the bone for maybe for our foot or our hand. The size is microstructure, and enlarge the bone. You can see the compact bone, and you can see also the cellulose bone, and the enlarge for the cardiac bone. You can see the osteo. About the large size is 100 micrometer, and we can enlarge the space of bone marrow. You can see the osteoclast, osteoblast. Their size is belong to the microstructure because their size is micrometers. And we enlarge the osteo. You can see we can get a collagen fibers. The radius of a collagen fibers is 0.5 micrometer. It's about 500 nanometer. So in here, we can call the nanostructure on here. When we enlarge the collagen fiber, you can get a 3 prolonged triple helix. About the size is extra, and the meaning is the sub-nanostructure. In our research, we emphasize the size for the microstructure and the nanostructure in the bone research. There are 3 R for bone issue. The first is repair, because if somebody his leg or his hand is broken, after 3 months, the bone can connect together. We can call it the repair. And now we can use the implant to do the reconstruction for the second step. If you use the titanium bone implant, we can reduce the bone repair time about 1 month. Finally, until now, the tissue regeneration is very important. We can use the stem cell to group the bone cell, and finally put on our broken leg. Then the broken leg can grow very quickly. Maybe the time is reduced to the 2 weeks or 3 weeks. So motivation for this research, PCL was blended with graphene practice during fabrication of scaffold to see the influence of graphene pellets on PCL scaffold. The presence of graphene practice in PCL-based scaffold was expected to improve the problem mentioned in previous slider. Now I will talk about the materials and the method. This is a graphene. You can see in the left, in the right side, this is the TEM picture for the graphene. And in this research, we use the PCL on here. Average molecular weight is about 80,000. Melting temperature is 60 degrees. And in this research, we use the solvent testing pathogen method to produce the scaffold. This method is very simple and low cost to produce the scaffold. The first, we put the PCL, put the graphene, put the NaCl on the mold, and the solvent, and finally we put the solvent chloroform on in this mode, and the function is dispersed the PCL. The function, fabrication time is 12 hours, and finally we can make stator for 2 hours. And because you know the chloroform can disperse the PCL, we mode a scaffold on the mold. The mix with the power into a mold and dry at the room temperature for 90 minutes. And we can use residue chloroform remove. Residue chloroform is removed by molecular drying at 25 degrees C for 12 hours. And the particle lynching, the scaffold is put on in the DI water at 55 degrees C for 2 hours because the water can dissolve the NaCl. So we can make a porous scaffold in here. The scaffold was drying in a molecular oven for 25 degrees C for 12 hours. Finally, we can get a very well scaffold on here. This is the sample for scaffold. We use the PCL plus the 0.05% graphene, PCL plus 0.1% graphene, PCL plus 0.5% graphene, PCL plus 1% graphene, and PCL plus 2% graphene. If we added more PCL, the scaffold become to the black colors. How to measure the porosity? We use this formula. P is equal to W1 minus W2 over density E over the W1 minus W2 over density E plus WS over density S. These formulas you can see in so many papers. Because the first, we will measure the surface property for the scaffold. We use the contact angle meter to measure the scaffold contact angle. You can see for the contact angle, if the contact angle is smaller than 90 degrees, the properties of the test piece is the hydrophilic. If the contact angle is larger than 90 degrees C, the test piece is hydrophobicity. And because the strength for the scaffold is very important, finally, we will put a strength in a broken leg. So the Young's modulus and the strength is very important for scaffold. We use the mechanical test machine in here. You can see this machine, and to measure the Young's modulus and the strength for the scaffold, we can cut the scaffold as the diameter 6 millimeter, the height is 8 millimeter. We use the test machine, use the speed is 1 millimeter per minute, and the strain level is about 70%, sorry. And to the degradation test, the degradation of PCL is done in 2 steps: redden, hydrolysis ester cleavage, and the weight loss through the diffusion of the olometric salt from the volume. Degradation condition were put on the 37 degrees C, 5% CO2 in PBS. Weight loss and pH value were measured per week. The test was tested for 15 weeks. Why we use the 15 weeks? Because 15 weeks is close to the 4 months. Because I have tell in the pressure slider, if our leg or hand was broken, after the 3 months, the broken leg will connect together. The weight loss is use this formula. W loss is equal to W initial minus W degradation over W initial. For cell culture, because our research emphasizes the bone cell research, so we'll use the cell type is MZ63 for the 37 degree C, 5% CO2 atmosphere environment. We use the DMEM as the cell culture. We use the 0.25% tracing EDTA. We use the cell sitting in the 1 multiplier 10 degree 4 cells per microliter. The first, we do the MTT assay. The MTT assay, we can do the cell visibility for the cell numbers. Results were observed on the first day, the 4th day, and the 7th day. MTT assay, we use the subordination solution and use the elixir to see the apersals. ALP assay. ALP is kind of the hydrolysis enzyme produced by cell during dilatation. So if we use the ALP assay, we can measure the quantity of cells. Results was observed at the first 4th, 7, and 14 days in the cell culture. Now I will talk about result and discussion. This is the TEM image for the graphene tablet. This is the surface morphology from, you can see PCR plus 0.05% graphene to PCR plus 2% graphene. We can measure the pore size in this research. About in here, suitable pore size for the Crocon 260 micrometer for Professor Pawinru in 2008. In this research, we can measure our pore size from the 200 micrometer to 350 micrometer. So the size for the scaffold, the size for the pore is very suitable for Professor Pawinru research. The surface roughness, we also can see the surface, you can see for a different scaffold on here. This is a slide that shows the SEM image for cross-section. The left side is the PCR plus 0.05% graphene. The right side is the PCR plus 2% graphene. For the porosity, you can see for a different percentage graphene, we can get a porosity is larger than 80%. For the Professor Hartmacher in 2000, the porosity must up to the 80% that can to the scaffold to grow the bone or the other cells. For contact angle, you can see our research. For pure PCR, the contact angle is the 113 degree. So the pure PCR appears the hydrophobic properties. If we use the PCR, added a different graphene percentage on here, all the scaffold, you can see the contact angle is smaller than 90 degrees. So we can know the PCR plus graphene and the properties of the scaffold change to the hydrophilics. For the compression test, you can see pure PCR, the maximal stress is the minimum. When the PCR at a different graphene, the maximal stress increase on here, especially in PCR plus 1% graphene, we can get a maximal stress on here. For pH value vibration, the -9 is the pure PCR. The 79 is the PCR added various percentage graphene. You can see for the pure PCR, after 15 weeks, the pH value is smaller than the 7. For the other scaffold, for the PCR, added different percentage graphene. Their pH value after the 15 weeks, the pH value also larger than the 7. So we can see if the PCR plus the graphene can improve the properties of the scaffold. This slide shows the weight loss. The -9 is the pure PCR. The 79 is the PCR added different percentage per graphene. For the -9, after 15 weeks, the weight loss has the maximum on here. If the PCR added different percentage graphene, you can see the weight loss is smaller than the pure PCR. For the MTT assay, for the day 1, day 4, and day 7, you can see here for the PCR, for the PCR added a different percentage graphene. In here, we can see the PCR added 0.05% graphene can get a maximum OD value on here. In this slider, because the ALP assay can measure the quantity for the cells, so the ALP assay is very important for cell culture. In the day 14, you can see here for the PCR, plus 2 percentage graphene can get a maximum OD value for ALP assay. So in here, we can see the PCR added 2 percentage graphene can get a cell differentiation very well on here. This is the ALP assay for concentration. You can see the same result for PCR plus 2 percentage graphene can get a maximum ALP concentration for the day 14. So whether to measure for the ALP assay, we can get a good result for the PCR 82 percentage graphene scaffold on here. Now we can show the SEM for cell in the 7 day on here. For the PCR pure 0.05 percentage graphene, the cell grow together like a round shape. As the percentage graphene added up, so you can see the PCR plus 2 percentage graphene, the cell has the differentiation on here, and see maybe the one cell is expand to the 2 cell and the very good cell culture on here. Now I will make a conclusion for my research on here, and maybe we will talk about the future works. In our conclusions, the first, PCR plus graphene blended scaffold was successfully fabricated by solvent casting partially lynching method. The second, addition of graphene practice did not decrease the porosity of the scaffold. The number 3, graphene peptide turned scaffold into hydrophilic. The number 4, PCR graphene scaffold has better mechanical properties compared to the pure PCR scaffold. The 5th integration test, PCR graphene scaffold have a very good effect, the smaller effect on pH value or PBS compared to the pure PCR scaffold. Number 6, the degradation rate of PCR graphene scaffold are slightly decreased. And the number 7, we can confirm the bioavailability of a PCR graphene scaffold by MTT assay. Number 8, the scaffold with 2 percentage graphene addition has best ALP result. Number 3, SEM image show that MD63 cells can successfully attach and proliferate on PCR graphene scaffold. Now I will talk about the future work in our research. First, the other method to fabricate the scaffold can be developed in order to get higher precision of the process, like as we can use the 3D printing method to do the scaffold. The second, the electrostatic properties of PCR graphene scaffold can be solved in the investigate because we know graphene is the very good electrical conductivity. So maybe in the future we can use the PCR plus graphene scaffold under the electrical field to measure the cell culture. The third, different kinds of nervous cells can be set in PCR scaffold to observe the influence of the graphene on nervous cell. The fourth, the in vivo animal test is necessary in order to get further information on implementation of PCR graphene scaffold in animals. And in our concept, we can use the mouse, we can use the pig, we can use the dog for the animal test, can improve our result for the PCR graphene scaffold. And finally, thanks for your kind attention. That's our research is stopped on here. Thank you.
Thank you very much for interesting presentation. Okay, please, the audience, if you have questions. Okay, audience, please, if you have any question, please enter the question or direct to speak with Professor Sin. Please, the audience. Okay.
等一下，我再给你换奶哦。
Okay, please, the audience, if you have any question, please. Maybe before the question, I will make a conclusion to the presentation. Three-dimensional biomedical scaffold of porous biodegradable materials have been widely applied in tissue engineering for the course of bone repair and regeneration. This presentation shows the porous biomedical scaffold were fabricated by a solvent casting particulate launching method using Poly-E-Caprolactone or PCL as the matrix material. Graphene platelets is a add material and shoal as the porogen material. First, the mechanical properties, compressed strength, and physical property, porosity and contact angles, and the fabricated Sp.Pros scaffold were examined. And weight loss and variation in pH value of the PCL, graphene scaffold, and degradation tests were determined. The biocompatibility of the fabricated PCL graphene scaffold was determined by seeding osteoblasts like MG63 cell in vitro. Graphene improved the mechanical properties of 3D porous scaffold, and it changed the hydrophobic property of the surface and porous scaffold to hydrophilic property. A cell attachment and proliferation improved with higher ratio of graphene in 3D porous scaffold. So it's okay, Professor Sin?
Okay.
Okay, I think this time is over. Dr. Yossi, I will say thank you very much for the entrancing.
Professor Asma,
yeah.
there's a question in the Q&A box.
Yeah. Okay, okay.
There's a Q&A. There's a question in a Q&A box.
Okay.
Sorry, please repeat your question.
The question from Priscilla, resident for maxillofacial UNHAS is what are the tricks and system of OMS work in Panchong? What are the cases and how are the mechanism? And okay, and from Hokkaido, thank you for the presentation, Professor. Siapa ini, Yos? Okay, I think you can see in the chat, Professor Singh. Prof. Rahmadi, how about the setting, the circulation arrangement of the operation room or clinic room? Oh, ini yang tadi ya, Yos. Saya baru lihat, sorry.
There's a question from Isna Usnul. Hello, Professor. I'll ask about there are any special consideration of or condition to use before we choose PCL as scaffold. Thank you.
Okay. Thank you. Your question. I know. PCL is the polymer material, and PCL, it is the biopolymers, in the full world. So there are so many research use the PCL because PCL, PLA, and the PLGA is very popular material in the full world and maybe cheaper than the other polymer. So in Taiwan, we use so many research on PCL, but PCL has the weak properties for the mechanical properties. So if you use the pure PCL, cannot to use on the bone research because our bone, the Young's modulus of bone and the strength of bone is very big. So the pure PCL is PCL strength is not enough used on our bone research. So we must use the PCL at maybe the ceramic maybe add the graphene, I can improve the mechanical properties for the scaffold. Okay.
Okay.
There's another question,
Yes.
Professor. I think this is quite similar. Is there any special indication for the using of PCL?
Sorry, I cannot understand your question.
Is there any special indication?
Especially, research is any specialty? Yeah, yes, because you know, because the graphene is the very good, good material used on the to improve the mechanical properties. Because the graphene has the maxima Young's modulus and the maxima strength in the full world. And I also talk about in the future work, because graphene has the good electrical conductivity. In my lab, in the future, we use the PCL plus graphene to do the nervous cell research, because you know the nervous cell, our nervous system, that as the electrical field. So in the future, if you use the PCL plus graphene, can do a good research for the nervous system research.
Thank you very much, Professor. There's still another question. Is there any considerations in the aspect of biodegradability or bioabsorbability of the scaffold compared to other materials? Is there any consideration in the aspect of biodegradability or bioabsorbability of the scaffold?
That is your question?
Is there any consideration in the aspect of biodegradability?
Yeah. Yes, because you know, for my research, we use the scaffold on the bone repair. Because traditional, when the bone broken, must need 3 months, about maybe the 12 weeks to 15 weeks to the broken bone will repair. So we must do the degradation test for 14 to 15 weeks. But the pure PCL about the middle time for the degradation test, the PCL maybe will dissolve for the PBS. So if you use the pure PCL as the scaffold to do the bone cell research, so the this PCL material cannot match the degradation test in the PBS. When we added the graphene into the PCL, the degradation rate is very low after our degradation test. So that we can show the pure PCL, add as the scaffold material to do the bone research, maybe in the degradation test, has the very fair on here.
Okay, thank you very much, Professor. We still have 2 more questions. Thank you for the presentation. As the extent to which the material can be applied clinically to patients.
Okay. What?
How can, I think this is the question, how the material can be applied clinically to patients?
Please say again, sorry, because the voice. Please say again. Repeat.
How can the material be applied clinically to patients?
Oh, to patient. Yes, that's good. Because the PCL plus the graphene, we can make a scaffold for a round shape or a slitting shape. Especially for the school of dentistry, you know, in teeth, so many the teeth shape like the cylinder, so we can make a cylinder shape to input the teeth. The other, our hand and our foot, their shape also the cylinder shape. We can put this scaffold into the broken leg to repair the bone. and to let the nervous system blood tube can grow up in the broken leg. Finally, we can get the bone repair very quickly. Traditional the broken leg connection together will waste 3 months. In this measure, we can waste 1 month to do the bone repair.
Okay, thank you very much, Professor. This is the last question. Why is the addition of graphene will not decrease the porosity on the PCL scaffold?
Oh, because in scaffold, you must use the porous scaffold because we use the use the pore to grow up the cell. But if you added the graphene into the PCL to do this, your question is very well. There are so many questions in graphene added in the pure PCL because the graphene is very small, the size about a nano size. Because the nanometer size graphene induce the PCL, maybe we are grouped together for the van der Waals force. So we use the ultrasonic processing to make the graphene disperse very well. So if you want to repeat my research, you must emphasize for the van der Waals force between the PCL and the graphene.
Thank you very much, Professor. Professor Asma, please. I think all the question in question and answer box already been answered by Professor Yung-Kang. Thank you very much.
Okay, thank you very much. I think the time is over. I will be mungkin penyerahan sertifikat ya Yosi. Saya serahkan ke
yes, Professor, there will be a delivered of the token of appreciation to our speaker.
Professor Sen.
Okay.
Thank you very much for your time, for your great lectures. Very interesting. And this is your certificate. We will email you soon. Again, thank you very much, Professor Sen.
Thank you, Professor Rosalind. Thank you.
Thank you very much, Professor Sen. Give the applause for Professor. You can see.
Thank you. Thank you.
Thank you so much.
Thank you. Good wealth in Indonesia.
Yeah.
Okay.
Okay. Thank you,
okay.
Professor.
Thank you. Thank you. Thank you.
Thank you, Professor.
Thank you. Thank you. 应该是结束了吧？
Saya kembalikan ke Dr. Yosi.
Actually, Prof, we can continue to our next speaker. And you still as a chairman for the session, the chairperson for the session.
Okay, thank you, Dr. Yosi. Next session, I will invite Professor Dr. Gigi Boy Mohd Bahtiar, M.S, Ph.D, PBO. Before starting, I will read of the Sp.P of the second speaker. Selamat bergabung, Professor Boy. Prof. Boy.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, Prof. Boy. Terima kasih kehadirannya, Prof. Boy. Oke, saya akan membacakan riwayat hidup beliau, Profesor Dr. Gigi Boy Mohd Bahtiar, M.S, Ph.D, PBO. Kebetulan kami sama-sama di perkumpulan biologi oral, sama-sama pengurus di biologi oral dan sebagai PBO juga ya, Profesor Boy. Jabatan fungsional adalah guru besar, kemudian tempat dan tanggal lahir di Padang, 24 Mei 1952, alamat rumah di Citra Grand Cibubur, Bekasi. Pendidikan tahun 78 menyelesaikan S1 di Fakultas Kedokteran Gigi Universitas Indonesia, kemudian mengambil program Magister Ilmu Biomedik khusus parasitologi ya, Fakultas Kedokteran Universitas Indonesia. Kemudian tahun 1999 melanjutkan ke Faculty of Dentistry Kyushu University Japan, mengambil Immunohistochemistry course. Kemudian tahun 2002 melanjutkan ke RMT University Melbourne, Australia, mengambil transmisi elektron mikroskop and scanning elektron mikroskop. Kemudian 2001 sampai 2005 mengambil Ph.D. program bioteknologi di Universitas Melbourne, Australia. Kemudian 2018 meraih pakar biologi oral. Riwayat pekerjaan sekarang ini dosen di Departemen Biologi Oral di UI. Kemudian tahun 88 sampai 90 dia sekretaris Departemen Biologi Oral. Kemudian tahun 90 sampai 1996 2 periode ya Prof sebagai pembantu dekan 3 FKG UI. Kemudian tahun 90 sampai 96 adalah sekretaris Senat Akademik FKG UI. Kemudian 2006 sampai 2018 ketua Lab Biologi Oral FKG UI. 2010 sampai sekarang adalah reviewer nasional HIBA Riset Kemenristek Dikti Diknas. Kemudian 2012 sampai 2016 adalah ketua Senat Akademik FKG UI. Kalau publikasi jangan kita bertanya lagi, banyak sekali publikasinya di sini. Mungkin yang terakhir adalah RNA aptamer selected against cell inhibit Candida albicans biofilm formation in vitro. Itu di 2019. Kemudian makalah seminar internasionalnya juga begitu banyak, Prof. Maaf saya tidak bisa. Kemudian ada patennya itu sekitar 6. Kemudian paten terdaftar itu ada 3, award-nya pemenang 2 pada Universitas Airlangga, pemenang 2 penelitian di Universitas Mustopo. Kemudian ada serta rencana 30 tahun dari Presiden RI. Ini juga ada research grant, banyak juga ya. Terakhir itu 2019 saya lihat di sini HIBA Riset UI, Q1 Q2, potensi hambat molekul autoinducer 2 terhadap sifat kolaboratif Candida albicans dan kariogenisitas Streptococcus mutans in vitro. Oke, Prof. Saya kira riwayat hidupnya begitu banyak dan sangat bermakna.
Terima kasih.
Ya. Silakan, Prof.
Ya, terima kasih Prof. Asma, teman-teman sekalian yang saya hormati. I'm prefer to deliver in Indonesia, yes. Oke. Judul yang saya sampaikan ini adalah tentang interaksi antara Candida albicans dan Streptococcus mutans. Ini 2 mikroorganisme yang kita tahu sebenarnya komensal di dalam mulut kita. Yang saya akan sampaikan adalah current knowledge, kemudian future perspective, didasarkan pada beberapa riset dan riset saya sendiri yang terkini. Saya sendiri sudah disampaikan tadi dari Departemen Biologi Oral. Outline yang akan saya bicarakan hari ini, pertama introduksi, kemudian fokus riset yang saya lakukan selama ini, kemudian ada interaksi antara interkingdom, itu maksudnya bakteri dan jamur. Kemudian research yang saya lakukan di sini yang akan saya sampaikan adalah keterlibatannya komunikasi molekul, quorum sensing, antara bakteri di dalam mulut, dan apa kaitannya dalam mengintervensi interaksi antara Candida albicans dan Streptococcus. Halo, bisa didengar ya? Halo?
Ya, Prof, silakan. Bagus,
ya,
Prof.
Ya, maaf. Dan terakhir result dan discussion. Saya lanjut. Kita tahu di dalam mulut ini mulut kita itu adalah suatu ekosistem. Kalau ekosistem itu berarti ada penghuni, dan penghuni itu macam-macam. Ada bakteri, jamur, virus. Ya. Tapi saya tidak akan bicara yang lain, apalagi COVID di sini. Saya batasin aja ke apa yang saya lakukan. Kemudian current state-nya yang apa? tentang Candida dan hubungannya dengan berbagai bakteri di mulut. Yang penting di sini yang saya sampaikan adalah komunikasi antar mikroorganisme tersebut, itulah yang antara lain menentukan survivalnya di dalam mulut. Apakah dia akan tetap sebagai komensal atau sebagai patogen. Sekarang macam-macam soalnya hipotesis mengenai interaksi ini. Ada yang bilang itu benar-benar karena patogennya atau karena bakteri tunggal tanpa melibatkan teman-teman yang lain. Jadi kalau saya ambil fokus riset saya selalu starting di sini dari clinical studies. Saya kasih contoh nih. Jadi clinical studies itu saya pernah melakukan riset tentang epidemiologi Candida albicans dan setumutan di karies anak-anak, SCC. Nah, dari situ nanti kalau kita melacak interaksinya, kita akan tahu siapa aja sebenarnya yang terlibat dalam suatu kejadian itu. Ini saya kasih contoh, saya kasih lihat ini gambarnya. Pada keadaan sehat, misalnya ada bakteri A yang di situ lebih, katakanlah jumlah lebih tinggi. Kemudian ketika ada suatu penyakit, ini ada mulai ikut-ikutan. Nah, jamur di sini ikut-ikutan untuk membantu peran si bakteri tadi. Membantu dalam hal apa? Membantu survival si bakteri atau supaya dia bisa menjadi patogen atau tidak menjadi patogen. Di sini peran jamur. Kemudian ada bakteri lain juga ikut-ikutan. Nah, jadi di sini dalam keadaan healthy, disease, dan resolution, di sinilah yang saya maksud dengan interaksi. Nah, kita harus tahu di sini siapa di sini yang lebih berperan ketika ada suatu penyakit. Nanti saya kasih contoh di sini karies. Kemudian setelah kita mengidentifikasi siapa sebenarnya yang berperan di interaksi sini, apakah gram positif atau gram negatif, atau bahkan si jamur sendiri, atau mesti semuanya, tidak satu-satu. Itulah yang disebut peran biofilm. Nah, dari kita ketemu di sini, dari bioinformatik analisis yang kita lakukanlah eksperimental model. Apakah eksperimental itu secara in vitro, in vivo? In vivo itu bisa ke hewan, ya. Kemudian juga bisa juga melalui cell culture, itu juga termasuk semi in vivo. Baru kita, maksudnya apa? Kenapa kita mesti menggunakan model-model eksperimental? Kita untuk mengkonfirm, benar nggak kejadian yang kita ketemukan di klinik tadi dengan berdasarkan yang gambar paling atas ini, sesuai nggak kejadian dengan yang kita hipotesiskan? Kan sebelum kita melakukan eksperimen harus ada hipotesis. Sebenarnya siapa sih yang berperan di kejadian suatu penyakit ini? Bakteri, jamur, atau keduanya? Nah, kemudian untuk apa? Nanti selanjutnya kita kalau ketemu mekanisme yang menyebabkan mereka berinteraksi, baru kita bisa mengintervensi untuk kepentingan klinis. Nah, kita kembangkanlah strateginya nanti. Strategi entah misalnya kita mau buat obat kumur, kita mau buat vaksin dan sebagainya lah. Tapi dasarnya dari sini. Sekali lagi dari kita hipotesiskan siapa yang berperan dari interaksi ini, kemudian kita bikin eksperimental model, kita ketemu mekanismenya, kemudian kita intervensi. Jadi strategi apa yang kita akan gunakan dalam mengintervensi interaksi interkingdom namanya. Jadi interkingdom ini karena bakteri adalah prokariot, sementara jamur adalah eukariot tingkat rendah. Itu artinya ada interkingdom communication. Intinya di situ poinnya. Kemudian, nah ini yang saya maksud dengan interkingdom communication, saya ambil model di sini adalah model karies. Kita tahu karies itu tetap masih global health problem. Sampai sekarang belum ada yang bisa pastikan benar bahwa dengan katakanlah fluoride bisa menghambat karies, tidak juga. Atau dengan macam-macam obat kumur, maka tetap masih menjadi masalah global. Nah, ada yang mengatakan pada awal stadium pembentukan biofilm di permukaan gigi, itu sebenarnya tidak hanya Streptococcus mutans. Situ ada juga Lactobacillus, dan juga Streptococcus yang lain. Nah, kemudian semua itu berperan di dalam kejadian kariesnya sendiri. Mulai dari bercak putih, nanti kavitas enamel, terus sampai dentin, dan seterusnya. Nah, perlu diingat juga di mulut tuh tidak hanya bakteri Streptococcus atau gram positif, selalu ada juga mikroorganisme lain. Di sini yang saya tekankan adalah Candida albicans. Ternyata Candida albicans juga nih banyak laporan yang menyebutkan dia justru menyebabkan biofilm yang ada di permukaan gigi ini menjadi kariogenik. Nah, itu perannya Candida albicans. Nah, dengan demikian, timbul dari pemikiran saya, bagaimana caranya saya mengintervensi interaksi Candida albicans dengan setumutan supaya biofilm yang kariogenik tadi bisa dihambat. Artinya apanya yang saya hambat? Sifat virulensinya atau fenotipnya. Nah, kita tahu, tadi saya sebutkan ada komunikasi. Jadi ketika Candida albicans dengan setumutan berada dalam suatu environment, katakan di permukaan gigi, itu di situ mereka tidak sekedar berinteraksi fisik, mereka juga mengeluarkan produk. Produk lain itu antara lain digunakan untuk komunikasi. Ini mungkin pernah dengar ada quorum sensing. Nah, Candida albicans sendiri mengproduk quorum sensing juga yang disebut farnesol. Tapi fungsi farnesol ini sebenarnya menghambat hifa supaya dia Candida albicans tetap dalam bentuk blastospora. Ini farnesol yang diproduk oleh Candida albicans, begitu fungsinya. Sementara Candida streptomutan juga mengeluarkan produk quorum sensing yang disebut CSP. CSP ini molekul kecil yang berfungsi untuk membuat setumutan ini menjadi virulen. Ya, kompeten stimulate peptide. Ya, baru ingat saya namanya ini. Ya. Nah, sementara ada bakteri baik gram positif maupun gram negatif itu semua menghasilkan satu molekul yang sama disebut autoinducer 2. Ini nanti mungkin pernah dengar, autoinducer 2 ini diproduk baik gram positif, baik oleh gram positif maupun gram negatif. Nah, dalam hal ini saya ambil contoh adalah bakteri Agregatibacter actinomycetum comitans. Bakteri kita tahu adalah bakteri periodontopatogen yang gram negatif. Dengan demikian, saya ambil suatu pola, apakah produk dari bakteri AA ini bisa mengintervensi interaksi antara jamur Candida dengan Streptococcus mutan. Itu idenya. Jadi ini yang saya jelaskan bagaimana caranya. Jadi bukan sekedar fisiknya yang saya ambil dari bakteri AA ini, kemudian saya gabung ke biofilm Candida dan Streptomutan, tapi produknya yang akan saya pakai. Nah, ini saya sampaikan sebelum saya menggunakan eksperimen produk autoinducer 2 ini, itu saya harus mendapatkan suatu strain dari AA yang tidak menghasilkan autoinducer 2. Itu poinnya. Jadi nanti saya compare apakah AA yang sudah tidak menghasilkan autoinducer 2 masih bisa nggak menginjus biofilm atau interaksi Candida dan setumutan. Di situ poinnya nanti. Jadi pertama, riset saya pertama, saya buat dulu mutan dari dari AA ini. AA ini saya bilang tadi adalah gram positif yang satu-satunya molekul quorum sensing yang dihasilkan oleh bakteri AA ini hanya autoinducer 2. Kalau setumutan tadi saya sampaikan di atas, dia juga menghasilkan CSP dan juga menghasilkan autoinducer 2 memang. Nah, tetapi ada 2 macam jadi termasuk XIP ini, 3 macam malahan. Kalau AA ini hanya 1. Nah, dengan demikian kalau saya sampai di lab gen yang memproduk autoinducer 2 ini, artinya si mutan nanti tidak lagi mampu atau berpotensi memproduk quorum sensing molekul. Nah, terus Candida albicans seperti saya katakan tadi, dia itu sebenarnya hidupnya itu lebih banyak di lidah atau di mukosa dibandingkan dengan permukaan keras. Tapi dia kadang-kadang ditemukan sebagai biofilm pada dental prostetik. Tapi yang dampak dari adanya Candida albicans di dental prostetik tentu saja bukan dental prostetiknya, tapi mukosa. Jadi tetap aja Candida albicans itu sebenarnya bermasalah atau menjadi patogen kalau ada mukosa. Itu poinnya. Nah, penelitian kami sebelumnya, ini saya mau ceritakan dulu sebelumnya, bahwa kami telah berhasil meng-create mutan dari Agregatibacter actinomyces comitan yang tidak lagi memproduksi autoinsur 2 melalui deletion gain. Ini contohnya. Nah, pertama tentu saya buka website saya lihat gen dari Sterto AA ini. Ada ini, semua ini, ada yang hitam, ada yang biru, ada yang hitam, biru, dan biru tua nih. Nah, di tengah-tengah ini nanti akan saya delete. Saya delete, itulah dia gen dari LOX-S. LOX-S ini adalah gen yang menghasilkan molekul autoinducer 2. Dengan demikian kalau sampai saya delete ini gen, si bakteri otomatis nanti tidak lagi akan memproduk autoinducer 2. Nah, ini contohnya cara teknik deletion gain. Saya amplifikasi dengan PCR, regio ini, kemudian saya masukkan ke plasmid. Nah, masuk plasmid ini, di tengah-tengahnya gen yang saya buang tadi, saya ganti dengan ampicillin. Ampicillin resistant gen. Dengan demikian, kalau sudah masuk ini plasmid, saya konstruk plasmid ini yang mengandung resistant gen kanamisin, saya masukkan ke E. coli. Ini E. coli, nah nanti plasmid ini akan diperbanyak oleh E. coli. E. coli ini berperan sebagai mesin biologis. Dengan demikian, plasmid ini sudah saya perbanyak melalui E. coli, saya kembalikan ke wild type dari AA. Nah, akibatnya, si AA yang saya insert dengan plasmid ini, nanti gennya akan rusak. Gen yang menghasilkan, gen yang saya sebut LOX-S, yang menghasilkan autoinducer 2. Mudah-mudahan bisa dipahami, ini teknik deletion gain. Terus maksudnya apa? Pertama, saya uji dulu, apakah si mutan tadi bisa nggak mengintervensi kehidupan si Candida albicans? Ternyata bisa. Artinya, yang wild type kalau dicampur dengan Candida albicans tidak akan tumbuh sebagai biofilm, terhambat. Sementara yang mutan dari AA ini, kalau dicampur dengan Candida albicans tidak ada masalah. Candida albicans tetap tumbuh subur sebagai patogen. Nah, dari sini saya starting. Berarti si mutan ini tidak lagi mengsekresikan molekul quorum sensing. Nah, dengan demikian saya ingin buktikan nanti, kalau terhadap Candida albicans dia bisa menghambat pembentukan biofilm Candida albicans, pertanyaannya apakah quorum sensing AA ini juga bisa menghambat interaksi antara Candida albicans dan Streptococcus mutan? Karena di karies, mutan akan menjadi kariogenik kalau ada Candida. Artinya harapannya kalau saya intervensi dengan produk AA ini tadi, apakah interaksi tersebut akan terganggu? Nah, itu di situ poinnya. Mudah-mudahan bisa dipahami. Nah, ini contohnya. Jadi saya ingin buktikan bahwa AA ini bisa mengintervensi interaksi atau relationship antara Candida albicans dan Streptococcus mutan. Ini idenya kenapa sih mau diganggu-ganggu? Karena prinsipnya dental karies ataupun perio itu sebenarnya tidak ada satu-satunya bakteri yang bersifat patogen terus ujuk-ujuk menjadi dental karies. Tidak. Itu prinsip. Prinsipnya itu harus pertemanan atau biofilm. Nah, biofilm yang bisa menentukan siapa yang pantas hidup di permukaan gigi ini dan menghasilkan asam. Acetomutan tadi. Asam tentu saja melalui pH yang turun, gitu kan. Nah, ini berbagai teori mengatakan bahwa dental karies itu ada antara lain disebut non-specific plaque hypothesis. Nah, ini. Tapi ada lagi membantah. Ternyata non-specific plaque hypothesis tidak tepat. Yang tepat adalah ecological plaque hypothesis. Maksudnya apa? Ekologinya diganggu. Jadi bukan sekedar interaksi fisik antara Streptomutan dan Candida yang diintervensi, tetapi ekologinya. Jadi lingkungannya lah. Kan sebenarnya yang bikin karies itu memang ekologi, pH kan. pH yang turun, terjadilah demineralisasi. Sebenarnya itu yang harus dicecer lah, difokuskan. Bagaimana supaya ekologi itu tetap tidak bersifat asam, tidak sekedar mengintervensi bakteri. Kemudian ada lagi bilang, tapi tidak sekedar ecological plaque hypothesis, juga keystone pathogen hypothesis. Artinya, bagaimanapun, walaupun ada teman-temannya, tetap aja ada yang paling berperan di situ. Ada jadi kunci, yang memegang kunci di situ. Nah, itu ada yang menyarankan ini tahun 2012, dia bilang tetap ada patogen yang paling berperan. Benar, kita selama ini tetap menganggap setomutan yang paling berperan di dalam proses demineralisasi. Kembali ke awal cerita, setomutan tanpa teman-teman yang lain, dia tidak akan menjadi galak. Atau virulensinya justru tidak akan dahsyat. Gitu. Itu kunci-kuncinya. Jadi ingin dibuktikan apakah dengan pemberian produk bakteri AA akan mengganggu ke patogenisitas setomutan dalam kaitan interaksinya dengan Candida albicans. Situ poinnya. Jadi saya akan masuk di sini. Nah, ini sudah kami publish baru kemarin 18 Agustus. Ini kalau mau dilihat di PubMed Oral Science Wiley ini Q1. Jadi bagaimana caranya? Ini saya akan mengintervensi environment-nya nih. Jadi environment-nya antara setomutan dan Candida albicans. Saya medium dari pertumbuhan jamuran bakteri ini saya campur dengan medium dari quorum sensing molekul yang berasal dari AA. Nah, jadi hipotesis saya adalah jika saya campur AA, maka dia akan AA ini maksudnya produknya yang disekretin akan mengganggu mengintervensi hubungan antara Candida albicans dan setomutan. Jadi hubungan fisik antara setomutan dan Candida albicans terganggu jika medium pertumbuhannya saya tambah dengan medium yang berasal dari AA. Itu disebut span medium. Ini dia sesuai dengan judulnya. Jadi efek dari cell-free span media yang saya siapkan dari AA terhadap interaksi Candida albicans dan setomutan dalam dual biofilm. Tentu saja in vitro. Itu kuncinya di situ. Metode apa yang saya pakai? Pertama, tentu saja saya harus menggunakan well, saya campur Candida albicans dan setomutan. Kemudian apa yang saya ukur? Dampak dari pemberian AA ini, ini saya ukur adalah massa biofilm. Massa biofilm saya menggunakan crystal violet assay. Kemudian apakah selnya juga viabilitas dari sel baik Streptococcus mutan maupun Candida albicans juga terganggu, itu saya pakai metode MTT assay. Seperti Prof tadi duluan pakai MTT assay, tapi beliau untuk kultur sel eukariot, saya di sini untuk menentukan viabilitas sel akibat penambahan produk AA. Nah, tentu saja harus ada variabel. Apakah 1% atau 10% dari produk AA tadi? Yang mana berperan? Bisa dua-dua, bisa satu-satu. Artinya, seperti pemberian obat. Apakah ada dosis dependent di situ? Jadi, kembali ke cerita tadi, span medium yang saya pakai tentu saja ada 3. Pertama, span medium yang berasal dari AA lux S mutan, kemudian yang AA wild type, dan sebagai kontrol saya harus pakai juga AA ATCC. Artinya, efek dari AA wild type maupun AA ATCC minimal sama gambarannya dibandingkan dengan AA lux S yang sudah tidak memproduk quorum sensing. Nah, di sini ada 3 yang saya akan hitung. Pertama, massa biofilm. Massa ini artinya sel dan matriks. Biofilm itu ada matriks. Itu harus terukur semua. Dan yang bisa mengukur itu adalah crystal violet assay. Kayak gram staining aja. Selanjutnya, adakah sel yang mati antara Candida atau setomutan pakai MTT-assay terus dikonfirmasi dengan real-time PCR. Jumlahnya harus saya hitung. Berapa Candida albicans, berapa setomutan. Saya pakai real-time PCR. Jadi 3 metode ini cukup kemudian nanti divisualisasi dengan SEM. Ini contoh resultnya. Pertama, ketika saya ukur si interaksi antara kandida albicans dan temutan secara fisik, melalui crystal violet assay, saya lihat nih, bahwa ternyata pemberian span medium yang mutan tidak mempengaruhi interaksi kandida albicans dan mutan, yang hitam ini. Sementara pemberian span medium yang berasal dari baik wild type maupun ATCC turun biomass, masa biofilmnya. Nah, ketika saya ukur dengan MDT assay, jumlahnya juga turun. Nih, jumlah sel kandida maupun sel mutan. Baik konsentrasi 1% maupun 10%. Ternyata tidak ada bedanya nih. Artinya tidak ada pengaruh konsentrasi. Berapapun konsentrasinya, efeknya tetap menghambat biomass dan viability biofilm. Ini artinya. Kalau saya buktikan dengan visualisasi, ini pakai mikroskop biasa, pakai computerized, kita lihat nih, kalau dia diberi wild type, tetap ada interaksi antara kandida albicans yang panjang ini dengan setomutan yang boleh ditunjuk dengan panah merah. Demikian juga kalau pakai Lux-S, kalau quorum sensing dari mutan yang saya campur di medium biofilm kandida dan setomutan, ternyata tidak ada pengaruh. Hampir sama dengan yang kontrol, yang tidak diberikan medium. Nah, sebaliknya kalau saya beri wild type ataupun ATCC sama. Kita lihat setomutannya sudah kurang berinteraksi dengan kandida albicans, tapi kandida albicans tidak lagi tumbuh dalam bentuk hifa. Sini poinnya. Artinya kita tahu kalau kandida albicans tidak dalam bentuk hifa, itu artinya dia tetap komensal. Saya lanjut. Halo? Halo?
Silakan, Prof.
Ya, nah ini. Ketika saya buktikan dengan scanning elektron mikroskop, hasilnya juga sama. Kita lihat ini kalau kontrol masih ada blastospora, udah ada hifa baru mau tumbuh. Di sini juga kita hifanya banyak. Tapi kalau saya beri quorum sensing molekul, kita lihat nih, kalau Lux-S dia tidak banyak pengaruh, tetap ada grow si kandida maupun setomutan. Sementara si kandida albicans sendiri juga di sini tetap tumbuh dan ada setomutan. Yang penting di sini setomutan tetap tumbuh masih dalam bentuk ada matriks. Nah, ini yang putih-putih ini matriks. Ini matriks adalah glukosil transferase enzim yang menghasilkan matriks. Kita pernah dengar glukan kan? Tahu semua glukan. Glukan itu yang menyebabkan pH turun. Inilah dia glukan. Matriks ekstraselular yang putih ini. Nah, tapi kandida albicans sendiri tidak lagi dalam bentuk hifa, hanya dalam bentuk spora semua nih. Ini wild type, sementara yang E ini adalah ATCC. Jadi sama gambaran ini, tetap masih ada glukan, kandidanya tidak dalam bentuk hifa, dan setomutan masih banyak. Kemudian yang bintang-bintang merah ini menunjukkan ciri biofilm. Biofilm itu selalu ada rongga-rongga yang disebut untuk tempat nutrisi. Nah, ini rongga-rongga ini yang karena biofilm itu semakin dia padat, semakin tebal, di dalam itu semakin kurang nutrisinya. Jadi banyak bakteri mati. Tapi kenapa bakteri tetap survive? Di situ yang kita kalau pernah dengar teori biofilm. Jadi biofilm itu semakin tebal dia, semakin sedikit bakteri yang tumbuh. Bukan dari bakteri jumlah, tapi komunitasnya tidak variabel lagi. Hanya bakteri tertentu yang mampu hidup di dalam komunitas dengan nutrisi yang kurang. Kita bisa kebayangkan kalau penduduk sebegitu banyak, hanya orang-orang tertentu yang katakanlah bisa survive dengan kehidupan ekonomi yang susah. Nah, ini contoh biofilm juga begitu. Jadi tetap ada sel-sel tertentu di dalam ketebalan biofilm yang bisa survive. Itu yang bikin masalah biofilm, termasuk resistensi antibiotik. Nah, ini contoh lagi, ketika saya ukur dengan real-time PCR, ternyata Jawabannya hampir sama. Baik kandida albicans, ya, baik 1% maupun 10%, tetap turunnya drastis sekali dibandingkan dengan kalau diberikan wild type. Sementara yang setemutan turun tapi tidak sedrastis kandida albicans. Artinya kalau kandida albicans sendiri menurun, setemutan juga ikut menurun, tetapi tidak habis, katakan tidak drastis penurunannya dibandingkan kandida albicans. Nah, di sini poinnya, kandida albicans sendiri menurun bukan dalam hal jumlahnya, tetapi morfologinya. Jadi yang dalam bentuk hifa sangat sedikit dibandingkan dengan yang bentuk spora. Itu poinnya. Jadi intinya ternyata intervensi quorum sensing berasal dari AA tadi akan menahan perubahan morfologi kandida dari bentuk spora menjadi hifa. Yang patogen itu kan bentuk hifanya, kita semua tahu. Kalau kandida albicans itu yang patogen adalah hifa. Blastosporanya tidak patogen. Atau kita boleh bilang dengan kata lain, environment kita ganggu, silakan hidup di environment itu, tapi jangan bersifat patogen. Inilah kejadiannya, dampak dari pemberian quorum sensing AA. Ini kalau saya buktikan lagi dengan ekspresi gen, kita tahu gen AL1 dan HWP dari kandida itu menunjukkan hifa. Jadi ternyata ekspresi gennya baik ditambahkan quorum sensing 1% maupun 10% turun ekspresi gennya. Ekspresi gen yang mencerminkan hifa. Sementara ekspresi gen yang mencerminkan blastospora itu tidak terganggu. Ini dia, yang C. Kita lihat nih, yang C ini YWP1 tetap malah lebih tinggi dibandingkan dengan pemberian quorum sensing oleh LOX-S mutan. Jadi sini intinya hifa terganggu. Tadi saya buktikan secara visual, secara MTTC, kristal violet, dan sekarang ekspresi gen, hifa semua terganggu, tetapi yeast tidak terganggu atau blastospora tidak terganggu. Yang terakhir, kita lihat juga sini di Streptococcus mutan. Streptococcus mutan sendiri kita tahu dia menghasilkan glikosil transferase. Itu adalah enzim yang berperan di dalam perubahan sukrosa menjadi glukan. Nah, ada 3 gen di situ. GTFB, GTFC, dan GTFD. GTFB dan GTFC inilah yang galak. Yang sebenarnya insoluble. Sementara yang D soluble. Nah, kita lihat yang insoluble justru tinggi nih dibandingkan dengan medium yang mengandung quorum sensing dari mutan, AA mutan. Kita lihat. Sebaliknya pada D agak turun. Artinya satu mutan kehidupannya tidak terganggu dengan pemberian quorum sensing AA. Yang terganggu hanya kandida albicans. Nah, ini kita bicara sini karies ECC. Karena karies ECC sekarang dilaporkan kandida juga ikut-ikutan berperan di situ. Nah, kesimpulannya kalau mau mengurangi kariogenik setomutan bisa dipakai span medium AA ini untuk menghambat fenotip hifa dari kandida albicans. Kesimpulannya, studi ini memperlihatkan bahwa interference effect dari AA span medium terhadap kandida albicans dan setomutan relationship itu karena adanya auto-inducer 2, tadi quorum sensing dalam span medium AA. Nah, tapi dia juga ternyata juga pH-nya, waktu saya ukur pH-nya itu tidak di bawah 6. Memang masih di atas 6, tapi di bawah 7. Artinya tetap bukan dalam pH kritis. Kita tahu pH kritis, kalau kita pernah dengar kurva Stephen yang diajarkan pada anak S1, itu pH kritis adalah 5. Ternyata pH yang saya ukur tidak sampai 5, dia di bawah 6, tapi dia 6, tapi kurang dari 7. Nah, ini artinya keberadaan autoinducer 2 memang tidak drastis meningkatkan pH, tetapi juga tidak menurunkan pH sampai level yang kita sebut pH kritis. Jadi yang penting sini adalah AA itu bisa membantu equilibrium atau symbiotic relationship antara kandida albicans dan setemutan di dalam oral ecosystem. Dalam pengertiannya, silakan berinteraksi, tapi jangan kandida membentuk hifa. Nah, silakan aja berinteraksi selama masih dalam bentuk yeast. Nah, kita tahu bahwa walaupun peran kandida dan semutan ini interaksi sudah banyak dilaporkan, tapi tetap perlu riset bagaimana kita bisa menggunakan salah satu hasil riset saya ini, apakah nanti bagaimana bentuknya, entah dalam bentuk obat kumur, entah dalam bentuk katakanlah salep apa, itu nanti. Oke, sekarang sudah dapat idenya bahwa campur tangan bakteri periodontopatogen pada interaksi kandida albicans dan setemutan ternyata punya dampak. Nah, jadi riset lanjut tetap saja dibutuhkan. Saya rasa sampai sekian, itulah riset yang kami lakukan. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Prof. Boy atas ilmunya yang sangat mencerahkan, utamanya tentu saja bagi kami dari oralbiologi dan semua yang hadir pada saat ini, bahwa ilmu dasar itu memang sangat berguna untuk pengembangan dari keilmuan baik klinik maupun beberapa PPDGS di sini yang hadir. Mungkin ini juga berguna buat risetnya nanti. Ada juga yang kebetulan kami juga mau membuka S2, Prof.
Ya,
ini ilmu yang sangat bermanfaat. Saya kira mungkin saya membuka babak pertanyaan. Ini sangat menarik. Silahkan bertanya. Yang masih sempat gabung bersama kami ada 64 partisipan. Silahkan, saya bacakan Prof ya.
Ya, saya baca sini juga.
Assalamualaikum Prof, saya Inna Ibnu Residen Bedah Mulut. Bertanya, apakah ada kemungkinan jika hipotesa mengganggu interaksi albicans dan mutans dengan menggunakan bakteri AA, kedepannya dapat dikembangkan dengan maksud untuk menghambat proses dental karies yang sudah terjadi ke arah infeksi odontogenik yang lebih parah, atau hanya sebatas pada preventif dental karies? Terima kasih, Prof.
Ya, iya. Menarik. Terima kasih, Dr. Husnul, Dr. Ina Husnul ya. Ini menarik. Jadi sebelum terjadi karies atau setelah karies terjadi, begitu kan?
Iya.
Ya. Ini juga saya juga belum tahu persis, karena ini yang saya in vitronya kan saya uji dari awal interaksi dengan albicans. Tapi ini pertanyaan benar. Nanti kalau mau dilanjutkan ke eksperimen dengan menggunakan gigi yang benar, apakah sudah terjadi karies, bisa nggak dicegah jangan berlanjut lebih parah, atau masih gigi yang bersih? Itu pertanyaan di situ kuncinya. Ini sangat menarik. Silakan aja kalau mau dicoba. Ya, tidak terlalu susah maksud saya. Ya, ambil aja gigi, terus tentu saja kita buat nanti variabel yang gigi sehat dan gigi yang sudah parah. Buktikan dulu di situ banyak gigi yang sudah parah tadi, banyak kandida dan setemutannya harus ada dulu. Masih bisa nggak dia terhambat dibandingkan dengan gigi yang masih bersih. Ya kita taruh kandidanya dan setemukan dari luar. Setelah iya bagus Dr. Ida, terima kasih pertanyaannya.
Ya, ini menarik, Prof. Siapa tahu nanti dia punya riset, bisa kolaborasi dengan UNHAS dan UI, melibatkan Prof. Boy sebagai pembimbing. Mungkin insya Allah ya mungkin ada Pak Dekan di sini bisa mendengarkan. Terima kasih. Mungkin ada yang lain, teman-teman yang sempat hadir, silahkan. Bahwa studi ini memang membentuk pemahaman Prof ya tentang albicans. Ya, ekosistem albicans dan apalagi namanya mutans ya, dalam ekologi mikroba oral ya. Tentunya perspektif masa depan itu kita harus boleh kalian ada tapi jangan mengganggu ya.
Jangan nakal ya. Ya, begitu kira-kira. Ya. Karena dia program normal kan, jangan juga dimatikan.
Ada pertanyaan lagi. Di sini ada beberapa residen, mungkin ada calon S2, silahkan bertanya. Jadi Candida albicans dengan Streptococcus mutans memang dua hal itu memang selalu berada di rongga mulut ya Prof ya. Dia merupakan mikroorganisme komensal di dalam mulut. Nah, interaksinya itu bisa berubah mutualistik atau mereka bersifat sinergis ya Prof ya. Nah, inilah apalagi peran kita sebagai peneliti atau research untuk bagaimana mereka itu tidak bersifat membuat mereka tidak kuat, tidak sinergis.
Ini pertanyaan dari Dr. Erni juga menarik. Ya.
Oh iya, Prof.
Dr. Erni, ya, terima kasih. Riset saya tadi di dual biofilm. Pertanyaan beliau ini, bagaimana kalau dengan bakteri lain? Artinya bakterinya lebih dari 2 lah. Ini juga menarik. Pernah saya dual biofilm, tapi efekalis dengan Candida albicans. Nah, itu saya kalau bisa nanti buka di PubMed ada, saya sudah publish juga 3 tahun lalu. Nah, efekalis itu fisiknya. Ada 2 macam efekalis yang saya pakai, yang berkapsul dan tidak berkapsul. Ternyata yang berkapsul itu bisa menghambat mutan. Tapi yang tidak berkapsul, bakteri yang tidak berkapsul itu tidak mempengaruhi patogenitas dari mutan. Ini menarik, terima kasih Dr. Eni, boleh juga dicoba. Tadi kan cuma 2 bakteri. Padahal biofilm itu multiple spesies. Ya, bisa disimpan ini pertanyaan kalau Dr. Eni ingin meneliti, nanti bisa sama-sama kita uji aja, ambil plak gigi yang dari high caries, low caries. Nah, kita lihat dah, ngaruh nggak si quorum sensing AA ini. Terima kasih Dr. Erni.
Ya, mungkin ada lagi. Terima kasih Dr. Erni atas pertanyaannya. Mungkin ada lagi dari teman-teman yang lain. Silahkan. Terima kasih. Pernyataan Dr. Eni luar biasa, dengan senang hati sekali Prof. Mohon bimbingan.
Ya, terima kasih Dr. Eni.
Bisa menjadi penelitian hibah nantinya ya Prof ya.
Ya. Silakan aja. Yang penting kalau riset itu memang tidak akan selesai ya. Kalau selesai semua, kita dokter gigi udah pensiun semua ini.
Insyaallah semoga kita bisa kolaborasi.
Iya.
UI dan UNHAS. Oke, Prof Boy.
Baik.
Saya kira kalau misalnya tidak ada lagi, terima kasih banyak.
Ini ada satu
hari ini.
Ada di Prof. Henry Resident DM. Apakah efek fluorosen AA terhadap penghambatan HIV Candida bersifat permanen atau sementara? Oh ya, ini dalam riset saya ini juga bagus. Ini sangat maksudnya kritis. Harusnya pertanyaannya berapa jam interaksi tadi? Ini begitu bunyi pertanyaannya ini. Benar, terima kasih. Saya hanya melakukan sampai 48 jam. Halo Dr. Henry.
2 hari Prof ya? 2
hari. Jadi hanya sampai 48 jam. Selebihnya saya tidak ukur lagi. Pertanyaan beliau ini benar. Sampai berapa lama ini efek ini? Apakah sementara atau permanen? Ya. Saya rasa kalau 1 sampai 48 jam aja dia sudah, menurut saya ya, sudah terhambat, kesananya lebih-lebih lagi. Karena medium itu sudah terganggu. Sementara saya tidak tambah nutrisi di situ. Jadi dia hidup, kalau nutrisinya saya ganti. Bisa paham kan ya? Jadi selama 48 jam saya tidak ganti medium, saya hanya tambahkan AA, quorum sensing AA. Gitu Dr. Henry. Terima kasih.
Oke Dr. Henry, hanya 48 jam ya. Research yang dilihat dari Prof Boy. Silakan kalau masih ada.
Ada lagi nih, nomor 6 nih. Ya. Oh ya, sudah.
Yang durasi waktu tadi, Prof. Sama.
Ya, durasi. Terima kasih. Sangat kritis. Pintar.
Terima kasih. Mungkin ada teman-teman yang lain, silahkan. Silahkan. Ya, saya kira menarik sekali ya, Prof Boy. Pertahanan kuman sekarang, mereka juga mengalami mutasi.
Ya, benar.
Semakin teknologi semakin canggih, mereka juga membuat komunitas yang canggih. Sehingga interaksi mereka juga selalu ingin diteliti. Ya, silakan teman-teman. Kalau tidak ada,
Baik.
Mungkin kami minta applause buat Prof. Boy atas presentasi yang diberikan yang sangat menarik. Terima kasih Prof. Boy. Ya, mungkin saya kembalikan ke Dr. Yosi sebagai MC. Mungkin ada penyerahan sertifikat oleh Bapak Dekan Prof. Boy. Silakan Dr. Yosi.
Siap, terima kasih banyak Prof. Untuk selanjutnya akan ada penyerahan sertifikat kepada pemateri. Ya, kami persilakan mungkin Dr. Afif bisa ditampilkan.
Terima kasih banyak Prof. Dr. Boy.
Terima kasih Prof.
Atas waktunya, kesediaannya, meluangkan waktu, sharing ilmunya yang luar biasa.
Terima kasih.
Manfaat.
Ini Pak Dekan kan ya?
Siap Prof. Terima kasih banyak Prof.
Pak Dekan yang gagah Prof. Boy.
Iya, sudah pernah ketemu saya.
Iya,
Sehat
betul
ya?
Prof. Siap Prof. Terima kasih banyak Prof. Salam sama Prof. Linda.
Ya, makasih.
Sampaikan, makasih banyak.
Baik.
Ya, sekali lagi terima kasih banyak Prof.
Sama-sama semua teman-teman ya.
Siap Prof.
Alhamdulillah.
Banyak Prof. Nanti akan
Terima kasih Prof. Boy. Salam sama Prof. Endang dan teman-teman di.
Terima kasih Prof. Asma.
Iya.
Teman-teman. Assalamualaikum.
Ya, sehat ya Prof. Sehat.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Prof. Terima kasih banyak Bapak Dekan telah menyerahkan sertifikat kepada pemateri. Baik, hadirin sekalian, demikianlah akhir dari hari pertama untuk seminar ICOBTD kita yang keempat, sesi ketiga, dan kita akan melanjutkan ke sesi selanjutnya di esok hari.
Nggak ada foto, Dr. Yosi.
Siap, Prof?
Masih ada Dr. Boy bergabung, kita bisa foto mungkin sama-sama Pak Dekan.
Siap, boleh. Untuk dokumentasi, baik, siap.
Prof. Sin sudah live ya?
Iya, beliau sudah live.
Terima kasih. Makasih Prof. Boy.
Oke, pamit ya.
Makasih banyak Prof.
Terima kasih Prof. Semua teman-teman.
Terima kasih Prof.
Terima kasih banyak. Baik, kami informasikan bahwa untuk sesi keempat esok hari akan dimulai pukul 8 pagi dengan pemateri Dr. Jong-Yuk Kim dari South Korea dan Profesor Dr. Gi Ardo Sabir M.Kes. Dan untuk post-test kali ini akan dikirim, linknya akan dikirim ke email masing-masing peserta dan sertifikat akan diserahkan bagi yang passing grade dari post-testnya 70%. Kami ucapkan terima kasih banyak atas atensi dan partisipasinya untuk hari pertama, sesi 1 hingga 3 pada ICOBTD keempat hari ini. Sampai berjumpa esok hari. Selamat sore. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Yasi cantik.
Terima kasih Prof.